Good morning, good morning. Thank you all so much for joining us for our 2021 Men's Health Summit. We're excited to have you here, and we're gonna have folks trickling in. We had a good number of RSVPs, so we'll have some friends joining you hopefully soon here, but you're gonna get to hear the whole thing, so thanks for coming. Just to kick us off here, we're really honored to have the Mayor of Virginia Beach, Mayor Bobby Dyer, here to share a few words with us. Let me turn the platform over to him. Mayor.
Hey, how are you? Hey, good morning, everybody. How we doing today? Hey, I tell you what, fall is here, the weather's getting better, and guess what? Every day in Virginia Beach is a great day. But I'm honored to be here with you. This is not a competition. Men's health, all people's health, are very important. And today we're going to focus a little bit on men's health. Now, in my profession over the last 4.5 decades, I'm a licensed physical therapist. And I've had the privilege of working with many, many people. And I'm acutely aware of many of the problems and situations that affect men's health. And let me just say personally, my dad died back in 1963 from a heart attack. My brother died at 56 from a heart attack. And the other thing is, unique to men are things like prostate cancer. And I've known and had the privilege of working with many people that have had that. Early diagnosis is key to that. And then we also got colon cancer, heart disease, and a lot of, the shame is a lot of this is really preventable. Screening tests can find these types of things early. And don't forget, we're not invincible. Right now your mayor is 71 years old. I remember Leave It to Beaver on the first run, back in the 50s. It's important to get these screening things. Don't wait. Your doctor can be your best ally for maintaining and preventing a lot of diseases. Follow your doctor's treatment recommendations, such as high cholesterol, high blood pressure, and diabetes. And let me put it this way. I am on medication for blood pressure, and I'm also on a statin for cholesterol. So you're preaching to the Dyer choir right here. And be safe. Whether it be driving and things, but your lifestyle is up to you. You are the best controller of your own particular destiny. And take a serious look in the mirror and say, boy, what do I have to do better for myself? But let me just say, as a healthcare provider over the years, and maybe somebody who's been guilty of some of the sometimes neglect, you just kind of notice things, but it'll pass. Peace and terror systems, but we have so many specialties where we're recognized as having many, many fine hospitals and doctors. Don't hesitate to avail yourself of the services that are here, whether it be taking care of your prostate and get your BPH checked regularly. And like I said, I've worked on quite a few folks that had prostate cancer. It could be preventable if it's caught early. If you think you're having problems with cardiac, diabetes, get your sugar under control, because diabetes, it affects your vision, it affects your circulation, it affects your quality of life. And the thing is, thank God, over the years, lifespan is increasing now. Back in the day when I was a young child in the 50s, 70 was really old. But I don't think it's that old anymore. Things are better. Our quality of life is improving. But I think by the fact that you're here today is wonderful because you care. But listen to these professionals. They're here to help. And guess what? Here in Virginia Beach, we have opportunities. We have rec centers that you can go to work out. We're going to be opening up a lot of these things called pickleball courts and things of that nature, okay? You know, we have a wonderful boardwalk where you can get out and walk. We have places where you can go out and go kayaking. Take advantage of your city. Stay healthy. Thanks for being here, and God bless all of you.
Well, once again, thank you, Mayor Dyer. Thank you so much for that message. I really appreciate that. And thank you all for being here, and thanks to those who are joining on the live stream. You all signed up early and got a seat here in the room. We did have to cut off our in-person attendance, so we had a really good number that may be attending virtually on the live stream. So we welcome you all as well. But, you know, this is Men's Health Virginia. We started back in 2017 as a division of Urology of Virginia. And this conference we started back in 2019 for the same reasons, really, which is to get the education to patients, to get the knowledge into your hands to make the right decisions for your health. And so that's what today is all about. We're going to go through a number of different topics that are relevant, both that come from us as urologists. We're going to talk about testosterone and the prostate and sexual health, but also many of the sponsors and the vendors who are here today. So I do encourage you as you go out and stretch your legs, go to the restroom, grab a snack, to please stop by and visit them. They're just along the back hall here as well as along the side. You will get some follow-up information after the event with more information about each of the vendors, but do stop by and visit with them. And you know, it's really incredible the advances that we've seen in healthcare over the last years and said. And so we're going to really showcase that. And a few quick housekeeping notes. So each speaker will have a presentation, and then at the end of that we'll have some Q&A. So microphone right here in the middle. If you're able to submit questions virtually, I'll try to ask those on your behalf to the speakers. But please do feel free to have questions. I'm sure many others in the audience are wondering the same thing, so feel free to step up and ask. That'll be at the end. Save your questions for the end of each of the speakers' sessions. There will be a break about halfway through, so you can go out and, again, mingle around a little bit with all of our sponsors. And I think that's about it. I know we're running a little behind already on time, so I think we should go ahead and just kick off with residency training at Vanderbilt, followed by his cardiology fellowship at the Mayo Clinic, and truly a great resource for us and a great speaker. We're so happy to have him. Come on up.
Thank you so much for that kind introduction. Thank you guys for coming today. My name is Deepak Talraj. I'm one of the cardiologists with Sentara Cardiology Specialists. I serve as Director of Cardiology at Sentara Virginia Beach General Hospital and one of the leads at the Heart Hospital in the Structural Heart Division. I love cardiology. I've been in practice here for 20 years. I actually grew up in Virginia Beach, went off to do my training, and came back this way, and it's an honor to be here with you today. All right, so this is a hard field to do justice to in 20 minutes. So I'm going to do two things. I'm going to show you a lot of visuals in my slides to come, and I'm going to talk really fast because I want you to get the experience of what's going on. This is a men's health conference. Obviously, I'm focused on that, but most of what I'm going to say is applicable whether you're a man, woman, child, teenager, whatever your category is. We're going to look at cardiovascular care in 2021. So my job, what I do on a daily basis, is I work in the cath lab. I put in stents and heart valves and things like that. When I take call, our system here, the Sentara system, it's 12 hospitals, 14 outpatient practices throughout North Carolina and Virginia. The Heart Hospital and the Beach General Hospital are our two flagship hospitals. So we'll take helicopters with patients having heart attacks from the Outer Banks, from the upper part of North Carolina, from as far in the direction of Williamsburg and Suffolk and Portsmouth. The reason I bring that up is, so I was on call last Sunday night, and we took care of 4 patients with heart attacks. 3 of the 4 survived. 1 expired in a helicopter on the way to us, and we did compressions and CPR. Heart disease is real. That's part of my life. That's what we do every day, is take people having heart attacks and fix them. And in fact, to give that point some perspective, we're lucky. We live in an area where we have tremendous medical care. The cardiac program here is in the top 50 in the nation, and that's on the U.S. News and World Report surveys. That's not just some, a lot of times 4 out of 5 dentists recommend something. This is the national surveys that tell us that. When you think about your heart, it's truly an amazing organ. When I was in my undergraduate medical school years, I thought I wanted to be a neurosurgeon and neurologist. And then I did my rotations in that. And the brain is a fascinating area. The problem is we don't have a lot of great ways to fix stuff going on with the brain, even in 2021, 25 years later. The heart, it's remarkable what we can do. We know the electrical system, the plumbing system, the hemodynamics, the mechanics, the valves. There's lots of things we can do. So if you think of the heart, there's no human-made structure or pump that can work beating 60 times a minute for an entire lifetime with no breaks. It doesn't stop. And if you think about the heart from a cardiologist standpoint, one important area is the roads of the heart. It's like the highways of the city. And I'll tell you, one of the patients this week we took care of was a 50-year-old airlifted to me with an acute MI, an acute myocardial infarct or heart attack. He was having crushing substernal chest pain, a history of diabetes, high blood pressure. And if you'll play the video, I know you haven't seen pictures like this before, but this is what we did in the cath lab, is I put catheters in the IVs in his leg, and we took pictures of the arteries. Those black lines are the arteries. And if you look carefully, you can see there are some areas that are thinner and some areas that are thicker. That's where there's cholesterol. It's moving because the heart's beating as we're taking these pictures, as he's having a heart attack. Next slide, I'll show you the right coronary artery. Now, for those of you that haven't seen one of these before, if you'll play this, the real thing you'll notice is there's not much on the screen. This artery is completely blocked. There's no blood flow going to about 30% of this gentleman's heart. That's why he's having a heart attack. And so what do? One of the therapies that's most commonly used for a treatment of this problem is a stent. So we use a balloon with a little coil, sort of like a spring inside a pen, to expand and open up that blocked area. And so in his case, if you'll play this image, what you'll see is, I know these are faint to project, but there's two black dots and between them a gray area. That's me putting a stent in his artery. And you remember earlier, you just saw a little tiny bit of dye going down and it was basically occluded. As soon as we put in the stent, his pain goes away, and when we play this, you'll see now the return of a completely normal-looking rest of the artery, with flow returning to 2/3 of the heart. And as a cardiologist, this is fun to see, because you have someone who's really sick, their blood pressure's low, they're in excruciating pain, and the minute you get that artery open, for most people, they start noticing a dramatic difference and feeling better. We can see an immediate result. It's an instant gratification. That's fun as a practitioner to see that kind of difference. Now, we've already alluded to the technology available to us. One of the points of today's talk is that's a little bit of a tragedy to have a situation where someone's coming in, helicopters, it's expensive to provide care like that. What I would love to do is prevent that from happening, not only because it keeps me in bed in the middle of the night, but more importantly because it's better quality of life. We have amazing technology now. If you'll play this, this is a gated cardiac CTA scan. It lets us see what we can see with a cath with a CT. We're always careful about sharing patient information. This is actually my own scan. When we took our scanners online about a decade ago, we needed some of us to volunteer to be the test cases. So this is my scan. You can see the heart muscle, just like I showed you the cartoon earlier. You can see the arteries running on the surface, as well as arteries in the lungs, my ribs and spine on the side. We can drill down from different angles and see every aspect of the anatomy of the heart. That scan can be done at most of our hospitals in the region, and it's a wonderful predictive tool for the right patient. I wouldn't everyone go home and tell their doctor they'd like a cardiac CTA because there's radiation exposure and other things. We always individualize to the patient as to what's right. The point of my showing you this is it's remarkable if we do prevention and diagnostics, how we can keep people out of that situation of a heart attack. This video goes on and on because I show drilling into different parts and chambers, but I'm going to keep going. That's a zoom in on the artery of the front of the heart, and you can see every branch. All this with just a CAT scan, and we can drill in, look in different ways, and see an amazing amount of detail that really a decade ago, this just wasn't possible. All right. And for instance, if that patient that I showed you having the heart attack, if we had looked a little bit earlier, on the right is a blockage on a cath. Again, you can see this artery is not completely blocked, but it's probably close to 99%. And on the left is an equivalent CTA, showing us right before the artery blocked, what would it have looked like. At that point, in fact, Friday night, I got a call from a patient who'd been having chest pain for a little bit. We got a CT scan on them. I know that patient now has a 70% blockage on the artery on the right. They're going to take it easy this weekend, and Monday I'll fix that at the beach. So in addition to CT scans, we have other technologies. If you'll show the image on the right, this is an ultrasound-based, what we call an echocardiogram. We can see the beautiful valves of the heart moving. We can see the muscle. This is a non-radiation-based technique to see exactly what's going on. The technology really is unbelievable what we can look at now. Like I said, I've been practicing 20 years. When the first generation of portables came out, I remember taking one to my son's grade school class and showing the kids an echo of their heart. It's really amazing what you can see and what's going on. The good news is we have great technology. One piece of sobering news, and I'm director of the Workforce Planning Committee for the Sentara Cardiology Division. I'll tell you, we are aggressively interviewing cardiologists. There are not enough providers, physicians, nurses, nurse practitioners. It's always frustrating for me to hear from a patient that they've been on a waiting list for 2 months to see me, and pretty much all around the community, whether it's cardiology, neurology. It is amazing the backups we're seeing, and we're at our peak. This is pre-COVID. COVID has accelerated the reduction in the number of healthcare personnel in our area, and the reason I say that is, I'm sure many of you see this. Every day I have patients. Yesterday I was in clinic, and probably 6 patients told me their primary care providers are retiring. Who else can they see? They've called 10 different people and are having a hard time getting in. The reason I put this into this talk is it's incumbent on all of us as human beings, as part of the population of the area, to do what we can to keep ourselves healthy. The healthier we can all be, the further our resources will stretch in taking care of patients. I'll tell you, with COVID having a little bit resurged in the area, in the heart hospital, in the beach hospital, we've had days we've had to cancel all elective procedures. And as a cardiologist, it's really frustrating when I have a patient that's been waiting for a while, we've taken time to line it up, they've been fasting, we've done all the blood work, and we find we have to cancel 5 cases that day because there are simply no ICU beds to take care of people afterwards. So it's a time of great stress on the medical community and resources as a whole. And that's why the message of today, prevention, is so key. So, Jim's going to talk after me. Jim White and I are very good friends. We've done a lot of talks together. I've been able to cut out a bunch of the slides I would normally use because he's going to tell you a lot about fitness and nutrition and what you can do there. But just to highlight the point again, what can we all do? 1, learn to eat right. That's something all of us can do better. I have chaired a number of conferences we've had locally on different nutrition programs. There's a vegan Ornish program we talk about every year, and whenever I usually am the chair and MC of that, and everyone comes back saying, gosh, I didn't realize you were a vegetarian. I'm actually not a vegetarian, but I do think that's a tremendous lifestyle, and if I were more committed, I eat a lot of fruits and vegetables, but the point is eating healthier. It's 3 simple rules: less food, more fruits and vegetables, and real foods. If it comes in a box or a bag, if it can last on your shelf for a year, it's not food, right? It's designed to be addictive. The food industry is going to be where cigarettes were, 10 years ago. A lot of stuff's coming out that's, when you're trying to sell something, you do what it takes. Salt, sugar, and fat are all tasty. Those are the things you pack it with. So real food. If you think that's just a common sense, well, it sounds good, but isn't that important? This is a medical slide we show very frequently, and I think it's critical to understand what we're looking at. We're looking at an actual measure of the reactivity of the arteries. This is in the forearm. They measure arteries in the hand. And the white dots going across, what those are is a person fed oatmeal, and then for the next 6 hours, we look at their arterial reactivity. And after eating oatmeal, there's consistent arterial function for the next 6 hours after a meal of oatmeal. The black dots are someone who just ate a McDonald's cheeseburger. And for the next 6 hours after eating a cheeseburger, arterial function has a sustained drop that lasts about 6 hours before the arteries can act normally again. This isn't 10 years later that burger was bad. This is right after eating that. Immediately we can see the arteries don't work as well. That's real published data. It's remarkable when you see that. This is the kind of data we had for cigarettes about 20 years ago. Cigarettes, it's only about 30 minutes after a cigarette that happens, and it's a slightly deeper dip, but this is the same thing. Number 2, stop smoking. I'm not going to belabor the point. There was an interesting study they did in Helena, Montana back in 2010. They put a citywide ban on smoking, and what they noticed is in 6 months, there was an 80% reduction in acute heart attacks. There's nothing else I can do. There's no medicine, there's no procedure I can do that will get an 80% reduction in that short time interval. We already alluded to diabetes. Diabetes is a vascular disease. The way patients with diabetes ultimately die is from cardiovascular disease, so controlling diabetes is important. All right, hard to see this slide, I know. What this is a slide from the Journal of the American College of Cardiology, and I'll explain what you see. What's important is you just see that blue line that goes from high up on the left to down low on the right. That's cardiac mortality based on how much exercise per week a patient's doing. Sedentary people had the absolute highest cardiac morbidity and mortality. This is in patients with stable history of heart disease. If you did nothing, your risk, you can see, is about 4 times higher of dying in an average year of heart disease. And the more exercise you do, the better you get. But one thing that I think is interesting from this slide is the far right is greater than 180 minutes per week. And then it's divided into segments below that. The steepest decline in that graph is from doing nothing to doing something like 30 minutes of exercise a week. Just a little bit. We don't have to be perfectionists. We don't have to run marathons all the time. Getting out and just doing something, walking for 30 minutes most days of the week will get you as impressive a mortality reduction as some of our cholesterol medicines and diabetes medicines. So simple stuff makes a huge difference. The problem is this is lawn care in 1950 in this country. So you drag the cast iron push mower out of the cellar, you oil it, you cut the grass, stop for a drink of water from the garden hose, rake the grass, bag it, take it across the street and throw it in the neighbor's yard. And you use 3 hours of time, you burn 900 calories, you consume 0 calories. Now you fast forward to 2021. All right, 2021, you open the refrigerator, grab a beer, load up your favorite playlist on your Bluetooth headphones, press the garage door opener and turn the key and engage the mulching option, cut the grass while sipping the beer. It only took 30 minutes. Tremendous time saving is what modernity has brought us. But we burned only about 40 calories. It took some effort to press the garage door button. And the beer was 150 calories. So even after maybe what we consider the exercise for the day, we're net negative. So it's a hard choice, but what it comes down to is what fits better in your busy schedule. Exercising an hour a day or being dead 24 hours a day is what this cartoon shows. And that's why, again, there's simple things we can all do that's just a matter of getting in the habit of. And we'll talk about some interesting things around that. Another thing, underestimated is the importance of attitude and your outlook on life. This is an interesting, I showed you the nutrition slide looking at arterial reactivity. This is a neat slide because this came from a study in Georgetown, published about a decade ago. And this looks very scientific. Let me tell you what we're looking at. What we're looking at is on the far left, there's 2 curves, the left one and the right one. On the far left, they assessed arterial reactivity in a group of patients at baseline. And on the left, what they did was they had them watch a funny movie, and then they reassessed after 2 hours of laughing, how did their arteries do? And for the vast majority of patients, and you see the dark black line is the average, their arteries worked better after 2 hours of fun and laughing. They brought the same group of healthy young people back, assessed their baseline reactivity, and then they had them watch the movie Saving Private Ryan. Now, I paid to watch that movie, right? So that was kind of entertainment. That isn't the life stress of family issues, death of a loved one, job issues, things like that. That's entertainment, but it's stress. And you look, there's a couple weird people that had better arterial reactivity afterwards, not sure what's going on with them. But most people, after watching a movie like that, their arterial reactivity is worse after 2 hours of entertainment stress. I'm not saying don't go into entertainment stress, but you can imagine if that was the death of a loved one or loss of a job or divorce or something else that's really weighing on our minds, what it does to how our arteries work. In fact, in the last 15 years, we've seen more and more episodes of what we call broken heart syndrome. People that come in and for all the world, every test looks like they've had a big heart attack, but their arteries are completely open. It's all driven by emotional stress. I could talk for hours about that. It's a fascinating topic, but I don't have enough time. I would say one good thing I would tell you is the future is bright. If we can do some of the things we need to on our own and get ourselves healthier, eating right, exercising, stress reduction, quitting smoking, managing diabetes, that would be about a 50% reduction in the amount of heart disease we have to clinically treat. But there's neat things coming. This is a nice article, and we've done a lot of work locally on leveraging artificial intelligence. I could spend hours telling you about some of the projects we've been involved in and national projects. There's some amazing stuff coming. And just to highlight a few interesting things, this is the era of wearables. Whether it's an implantable device or an Apple Watch or a Fitbit or a million other things we can do, I think we're starting to enter the era, especially COVID accelerated this, of telehealth, of patients having access to things that can monitor information that can help us. Now, the problem is some of it is not very accurate. I will tell you, daily I get people who have long, hundreds of screenshots of Apple Watch data, most of which is incorrectly identified as a rhythm issue. The accuracy is about 50%. But some of these things, like the middle thing on there, is a device called CardioMEMS. One of my patients just sent a letter to the editor that was published in the Journal of the American College of Cardiology. During the COVID era, he's had very bad heart failure. We implanted that device inside his heart with it's a simple, you put it through an IV, and every day it sends us a level of his fluid levels, a measurement. So we can tell, it's like a fire alarm. We can tell 2 weeks before he's going into heart failure that it's happening, and we can call him and say, you need to do this or you need to do that. That device is one example of amazing new technology we have. He'd been admitted 4 times to the hospital before we put the device in. He's had that now for about 2.5 years, and he's had one single hospital admission, which was for an infection. He's had no more heart failure admissions, and his letter was published in this National Journal of the American College of Cardiology as a patient perspective, saying this is something that's really changed my life altogether. So very exciting stuff is coming. I've summarized a lot in a short time. Maybe I'll show you one last thing since I have a minute. Just bragging on the technology we have locally to Mayor Dyer's point. This is the latest generation of stuff. This is a hybrid operating room. We can do full operations and full catheter-based procedures all together. And this has pushed the envelope of what we can do. So the last 10 years, I've been one of our leads in our structural heart program, and it's been fascinating. 2008, if someone needed a valve replacement, it meant an open heart surgery, 5-day hospital stay, 2-month recovery. Nowadays, well, in 2011, we were in the first institutions in the United States putting in valves using catheters. Back in those days, it was 1 or 2 operations a day. Patients were still in the hospital like 3 days, and the recovery was maybe 3 weeks. Nowadays, we do 5 of those procedures a day. It takes about an hour to do. Most patients, including patients in their 80s, 90s, and we've even done patients in their 100s, are home the very next day with a full valve replacement. The longevity, it actually reduces costs by about 50% because it's so much shorter a hospital stay. And what we do is we do intensive mapping. These are ultrasounds, CAT scans. On the top left is a CAT scan looking at the arteries of the heart and the valve. On the right is an ultrasound where we can see the beautiful colors are the leakage through the valve. On the right is a heart cath like you saw on the right bottom. And on the left bottom is a CAT scan showing the bladder and the arteries on the legs so we can map exactly where we're going when we do this. This is the kind of valve that's mounted inside a stent. It's either a pig or cow tissue valve that's specifically designed to be able to put in through an IV and then basically deployed or put in place with a balloon. And I'll show you what I mean by that on this final video I have, if you'll play it. This is from a company called Edwards that makes one of our valves and is completely revolutionized. Everything is becoming minimally invasive. So this is the 3rd generation. We actually were in the trials that proved this was safe about 7 or 8 years ago. And so what we do is through the aorta in a patient who's sleeping but really sedated without being on ventilators or anything, we pass a balloon into this aortic valve which is narrowed. We use the balloon to stretch the valve, and then we take the balloon out. And then through that same IV in the artery in the leg, we can pass a valve that's been squished down so it's about, it's smaller than the size of my finger as it passes up through there. And we take that valve. It's designed so it's almost like a spaceship where the balloon that deploys it is outside it, and then in the body we pull it back in, and that allows it to be micro-sized so much that we can do this even in older arteries that have calcium plaques in them and so forth. And so once we've aligned that, we pass that under ultrasound into the old valve. It used to be we would have to cut open the whole chest, cut out the old valve, sew in a new valve in a 4 or 5 hour procedure with a patient on the ventilator and with bypassing the work of the heart. Now the heart's working while we do it. We basically take about 10 seconds to deploy the valve, and you'll see that. This is exactly how it looks. We put the valve into position, adjust its position. We can move it forward, left, back, right, with a team monitoring this carefully. You'll see that motion here. We have exquisite control from catheters on the outside. All the work is done really outside the body, and then once we've got it in the perfect spot, we use a balloon. This is showing it going in and out while we optimize and perfect our position, and then we rapidly pace the heart for 10 seconds, implant the balloon, take the balloon out, and what's left is a working heart valve. So it's remarkable. A huge invasive operation has been replaced. That's the future, is us taking care of ourselves, monitoring, advanced testing to detect disease before it exists, and then minimally invasive therapies to really get patients home and safe quickly. That's a lot of information at once. Thank you for your attention and for giving me the time to talk today. I see my buddy Jim in the audience. Jim and I have done a lot of these talks together, and so I've given you the kind of why we need to do this. He's going to give you advice on, oh, let's hear your question.
You said
Yeah. I love it. So my kid's now in graduating from high school this year, and he's going to do something in science, whether it's medicine, engineering, something in that realm. I will tell you one quick 2-second story. My wife's a pediatrician, and back in those days, we both went in to do Community Helpers Day and teach them. And my talk was definitely the cooler talk. I brought in masks and hats and Echo. She brought in a pack of Band-Aids for them. And at the end of the year, when they had the kids write down what was going on and what they wanted to do, my son did report to his teacher that when he grew up, he wanted to be a doctor, like his mom.
That's so valuable, and really appreciate Dr. Talreja coming down. And that dovetails perfectly, as he just said, with the next talk, which will be from Jim White. Jim is a personal trainer and a nutritionist who founded his own company, Jim White Fitness Nutrition, and has made a big impact on the community here, both from a philanthropy side and also just changing lives. And we're really glad to include this because, again, the heart health, the fitness, and nutrition is just going to be key to living the long, healthy life that we want men to have. So, Jim, come on up, and I hope we can get your fancy presentation.
Thanks to having me. Man, it's a hard act to follow. Me and Deepak for years have been speaking on the health of the area. And today we're going to talk about our area as a whole. Let's see if I can get this. There we go. And I'm going to have to start off morbid because nutrition's a serious thing. It's actually a life or death conversation. I like this English proverb, don't dig your grave with your own knife and fork. So if we really dive in and talk about the health of our men out there, we see that some of the top diseases in the United States, in fact, the top 10, we have about 5 of them that are all diet related. Heart disease, number 1. In the United States, someone dies from a heart attack every 36 seconds. We have cancer. We have some lower respiratory diseases, stroke, and diabetes is on the rise. So if we look at the country as a whole, where are we? And we see that 1 out of 3 people are obese in our country, and about 70% are overweight. And if we look at our children, 1 in 6 children are obese in our country. So we have a big problem when it comes to the United States. And what's happened since the 1960s, we see that the overweight trends are actually going down slightly, but what's happening is a lot of the overweight individuals are going into obesity. So we're seeing obesity drive up from the 1960s. Where do we rank in the state of Virginia? So we mentioned that 33% obesity in the country. Virginia is a little bit lower than that, 29 when it comes to the 50 states. 29th, and 1 in 3 have prediabetes, and 1 in 11 have diabetes. Approximately 1/3 have hypertension. So we can see we're right in the middle there. Where do we rank in Hampton Roads? So this is our areas here. The obesity rate in Norfolk is 31%, so it's a little closer to that average, and Virginia Beach is 29%. Believe it or not, Virginia Beach has been ranked some of the fittest cities in the United States. They base it on the amount of parks we have, the amount of gyms, the amount of fast food restaurants, and with that combination, we've been ranked top 15 for years in the country. But in the state, it's about 126 cities. Virginia Beach is ranked 26th, Chesapeake 37th, Norfolk 100, and Portsmouth 120. Does anybody live in Portsmouth over there? But yeah, that is close to one of the unhealthiest cities in the state. The American College of Sports Medicine estimates that 4.2 of the Virginia Beach, Hampton Roads population has coronary heart disease, and it's estimated that 11% of Hampton Roads has diabetes. All right, let's see. So if we look at some of the stats here, so why are we overweight and obese as a society? That's the one question we have to ask. And it's not rocket scientists. You know, we're eating too much. As we can see, the USDA estimates that we eat over 1,800 calories when it comes to women and about 2,400 calories when it comes to men. And they recommend for weight loss 1,600 calories for women and 2,000 calories for men. So that overage over time is what causes the weight gain. And we have to contribute a lot of it to the food that we have. Everything's supersized. If you look at portion sizes from the 1950s, we can see that our average soda has went up from 7 ounces. Now you see them up to 42 ounces. Your burger and fries have just enlarged, and it's cheap. You can go to the dollar menu at some of your fast food restaurants and get 5 items for $5 and just loaded with calories. There's a study done out of Tufts University, and what they did was they took 1,000 respondents and they went to eat out, and they found they went to 123 non-chain restaurants. There was 364 meals analyzed, and the average consumption of these meals were 1,205 calories. Just think about that. And if you look at those estimates that we recommended for women and men, that's just about half of the day or even 3/4 of the day of calories. The American, Italian, and Chinese average right around 1,495 calories per meal. And 92% of those meals exceeded the energy requirements. So think about it. You know, we have a restaurant program in Hampton Roads. We've teamed up with about 75 restaurants. We work with a lot of these chefs. If it tastes good, they're putting in butter and oils and things like that. So let's just say you went to Outback and got a petite sirloin, broccoli, and a sweet potato. That sounds pretty healthy, right? So just that meal alone, probably the best thing you can order there is right around 900 calories. So not saying that we can't eat out, but it's truly amazing. If you notice, every chain restaurant that has 20 chains or more has to have their calories on the menu. They don't want to put their calories on the menu because they know people are going to see that and be like, wow, I probably shouldn't eat that. And not only that, the amount of sodium that's in these meals. So if people that have high blood pressure, it can really affect things. So we have to look, it's not just about nutrition, it's about exercise. And 21.7% of adults meet the physical activity guidelines for aerobic and strengthening. So the problem is that we're eating too much and we're not exercising enough. And what's the recommendation for the American College of Sports Medicine? It's 30 minutes of moderate intensity exercise 5 days a week, and that's aerobic exercise. And we have 2 to 3 days a week of resistance training, roughly around 30 minutes. Those are some of the guidelines, and only 21% of those are being met. So we have to look at the nutrition and exercise equivalents. We are what we eat. Look at what it takes to burn off some of these meals. 2 Oreo cookies, 280 calories, you have to do 1.2 hours of weight training. Or if we look at pizza, we have to do, what is that, over 55, 60, I can't see that up there, but about 65 minutes of biking. I had a client this week. He came in on Monday, and I said, how'd you eat for the weekend? He said he had 10 beers. And as we can see here, how many beers you have to, 4 cans of beers, 32 minutes of running. I said, you should just go out there and run for about 2 hours because that's what it's going to take to burn those alcoholic calories. So it's easier to lower your calories than it is to exercise because we're so busy. We only have so much time in a day. So me personally, I love exercise, but I'd rather not do as much, get to the recommendations, but cut my food down. And that's a great way to really make a change. So what we do know, people are dying from unhealthy lifestyles. We are more obese ever as a society, and we are overeating and not meeting the exercise standards. And not only that, there's a lot of conflicting information out there. 8 out of 10 people are confused on what to eat or drink. As a dietitian, I've been doing this for 20 years. Even I went to Wegmans the other day. I couldn't believe all the products there. You know, you almost need a nutrition degree to understand all the diets and it is a science. And we have a lot of the sensationalized media we see in Time magazine, eating butter. I thought that, you know, butter we shouldn't eat or we should limit. And then how about this? 2 minutes of exercise will stop the aging process. I only wish it was that easy. And then we have all the low carbohydrate diets. In the documentary, What the Health, it says that, one of the doctors says that eating 1 egg is as bad as smoking 5 cigarettes. So it's just not true. There's a lot of benefits to eating eggs in moderation. And I love this approach. Our food should be thy medicine. Our medicine should be thy food. It is sometimes better, of course, better in medicine, exercise and nutrition, because we see those top diseases in the United States and how nutrition can really relate it. I've been doing this, like I said, for 20 years. I think I'm a good sales agent. I can sell cars. I can sell insurance. I picked the health and nutrition field because there's not a pill in the world or all the money in the world that can give you the benefits that nutrition and exercise. How about skin health? Foods such as fatty fish and salmon and vitamin C and a lot of your collagen can help improve skin health. The GI system and microbiome, we find that foods that have prebiotics such as kimchi and chicory root and onions can help to improve gut health, or probiotics in kefir that can help the GI system, and fiber. We see brain health now can be improved with nutrition, such as walnuts and fatty fish. We see that sleeping, 7 out of 10 people have a major problem sleeping. And by overeating late at night and drinking alcohol can have a rebound effect middle of the night and can affect our sleep. We see immunity, and with COVID, you know, vitamin D, zinc, vitamin C has been known to decrease the severity of illnesses that can build up the immune system. Quality of life, 25% of people over age 65 have a poor quality of life. With, you know, continue on exercising and eating healthy, we can feel good into our 80s and 90s. And then building muscle. We lose about 10% of muscle mass per decade after age 40. So by keeping it up and by lifting and light, it doesn't have to be you have to go to the gym, 5-pound dumbbells, 10-pound dumbbells. You can have this everything at home, and you can build strength and really reverse that trend. What's the cons list of exercise? Well, you know, could it be expensive if you have a personal training? Sure. But doing it at home now, rec centers, you can get a membership for $100 a year. Exercise is boring. Well, I think if you're walking on the treadmill staring at your wall, that could be boring. But now online, there's so many exercise classes, so many exercise disciplines. I always say, if you don't like running or you don't like doing something, don't do it. Find something that you love. It's really about movement, even taking 5,000 to 10,000 steps a day as a goal. Exercise, I don't have time. Well, just a 30-minute exercise bout is only 2% of your day. We have 1,440 minutes in a day. So a 30-minute workout, I feel with a little bit of time management, we can fit it in. And then, you know, exercise is hard. And I always like to start with the 2-minute rule. So if you're not doing anything right now, start off Monday and do 2 minutes of something. And you're going to be like, well, that's easy. But the 2-minute rule is very powerful, because what happens is once you put on those shoes and get going and get those adrenaline hormones up, most of the time you do a little bit more. I think what happens is people go in and are like, well, I have to do an hour. And then they wake up and are like, well, this is just, I don't have time for this. I'm tired. So just start off 2 minutes and then go up to 5 minutes and then 7 minutes and 10 minutes, baby steps, and you'll stick with it. And just those micro goals can make a huge, huge difference when it comes down to it. So again, just doing the basics can make a big difference. So if we look at the dietary guidelines, we see that sugar, the Cleveland Clinic there's a study out showing that people that go over the recommendations of sugar, and that's 36 grams of sugar for men, 25 grams of sugar for women, increase mortality by 38%. So 1 can of soda has about 40 grams of sugar. Now this is added sugar. This isn't fruit sugar. This isn't dairy sugar. This is your added sugar. So you want to look now on our labels. It has added sugar. You want to look for that. Our fat should stay around 20 to 35%. Our saturated fat less than 10%. The average American's only getting 12.5 grams of fiber a day. So as you can see, for men, we need 28 to 35 grams. That's really important, decreasing cholesterol, improving our GI health, and then sodium. The average American consumes 3,500 milligrams of sodium a day. So we need 2,300 milligrams. If you have high blood pressure, right around 1,500 to 2,000 would be the recommendation. So where do popular diets fit in? You know, we have been doing this, and we've had so many clients coming in on different diets. Well, if we look at the timeline on diets, none of us were around the 1900s, but is the tapeworm diet. Can you believe this? What they did was they swallowed a pill that had a tapeworm inside, egg, and it hatched, and the tapeworm would grow, and it would eat whatever you're eating. So this is how extreme they were getting. So this is not just now, but as we can see, the cookie diet, I remember that in the 1970s, late 1970s, the Atkins diet was very popular, the banana diet, and the HCG diet. It's a 500-calorie diet, and people are given pregnancy hormones, and it controls your appetite. Now, if we look today, Mediterranean diet, that is I don't even call a Mediterranean diet a diet. I really think it's a lifestyle. There's a lot of benefits. As we can see, it includes a lot of the foods, such as your vegetables, fruits, nuts, seeds, legumes. It's associated with improvements of cardiovascular disease, cancer, Parkinson's, Alzheimer's. As we can see, it includes all food groups. I just was on the doctors last week, and I did a show on the Mediterranean diet and improving impotency and erectile dysfunction. So a lot of problems with erectile dysfunction is because of high blood pressure. So the Mediterranean diet has a lot of foods that actually help to lower blood pressure. There is about 30% of men that have high blood pressure complain about erectile dysfunction. So with the Mediterranean diet and with other diets that decrease blood pressure, it can improve that. So just that alone is maybe a reason to, start this type of lifestyle. And it's sustainable. Some of the problems is it recommends 1 to 2 glasses of wine a day, and it may not be appropriate for everybody. Maybe that's a reason you'd want to do it. And it's vague. It doesn't have a dietary protocol. So you have to almost maybe get with a registered dietitian to go on something like this to put it together for you. So that is one that, I wouldn't consider a necessarily diet. Ketogenic diet. So the ketogenic diet, it does work for weight loss. There's no doubt about that. Anytime where you're cutting down your carbohydrates so low, you do lose a lot of water weight. And if you're eating a lot of carbohydrates, of course, when you have a deficit, that's what causes some of the weight loss. There is some evidence suggests it may lower triglycerides and raise your good cholesterol. And it definitely is better on weight loss. The symptoms are fatigue, bad breath, nausea, vomiting, constipation, some sleep problems. It does limit your fruits and vegetables, and common sense, those are good things that we need in our diet. And then it is very restrictive. Most people can't follow it for a very, very long time. Paleo diet. This is not a bad meal plan out there in diet. It emphasizes on consumption of whole fruits and vegetables, less processed foods, low sodium. It's greater importance on glucose control, promotes weight loss. The problem is that it prohibits grains, legumes, and potatoes. Could have some health benefits to those. Exclusion of entire food groups can often be challenging, and it reduces fiber intake, and that's what we do need, especially as men. The vegan diet. So this is the exclusion of meat, poultry, fish, dairy, and eggs. So a lot of the research suggests that, obviously when you're eating plants, you can't argue with that. You're getting a lot of phytonutrients that fight cancer, fiber, decrease in saturated fat. The problem is it increases the risk for other nutrients that we need, such as B12, calcium, vitamin D, iron, zinc. If it's done correctly, it could be something that might be a good fit. However, it is a very restricted diet, and it takes a lot of planning and a lot of discipline. Intermittent fasting. So I don't consider this a diet. This is a pattern of eating. It may be good. The studies are mixed on it. I feel that people that exercise pretty intense in the morning, I feel that it's important to eat. Another side effect that is if people are skipping, if they're going 16 hours without eating in the morning, a lot of times I see a lot of my clients that they're starving at night and then they're binge eating, and that kind of defeats the purpose. So, what it does is it's a 16-hour window. So maybe you stop eating at 7 p.m. and then you again eat at 11 o'clock. It could reduce calories and that can create a deficit. There are benefits of breakfast. So again, you have to, maybe try it yourself, see if this is something that would be a good fit. If you have diabetes, it would be something you want to talk to your doctor about because, having low blood sugar if you aren't or you're not eating. There's a lot of detoxes out there, and what that, it removes highly processed food, sugar and sodiums. I guess that would be some of the benefits. But there's a little evidence that you can detoxify your liver. It does a pretty good job by itself. And there's exclusions of a lot of nutrients. If we look at Matthew McConaughey and Dallas Buyers Club, we can see that he did a juice cleanse and a diet. He lost 38 pounds. I don't know. I think he looked better on the left-hand side. So he looked a little unhealthy on the right-hand side. So those detoxes can do those to you. So the bottom line when it comes to fad diets, they don't work long-term. In fact, 80% of people gain their weight back in their first year and 95% of people gain their weight back in 5 years. Whenever we have to give up something, we usually wanted more. And then, losing 10 weight in 10 years that you gained in 12 weeks, realistically, it's not that easy. As a case study of one of our patients, he came in, was about 100 pounds overweight. He had heart disease, high cholesterol, high blood pressure, vertigo, sleep apnea, morbid obesity. And this took a few years, but you can see some of the improvements, amazing improvements. His cholesterol went down, triglyceride, blood pressure. He actually went off of all of his medications. His sleep apnea he went off his CPAP machine. He started strength training. He started eating healthy. You can see his diet before, breakfast, eggs, grits, butter, muffin. He skipped some meals. He has sub Mountain Dew a lot of the days a week, lasagna, Caesar salad, Ben & Jerry's. And then he switched to a Mazda Pro. So he actually ate more times a day, small meals. And this actually made a big difference. His metabolism started improving. He started walking. He started strength training. And it's just those slight differences happened every day. And he was losing 2 pounds here, 3 pounds there, 4 pounds here. And it made a difference over the long run. And he did 10,000 steps a day. He did 4 days a week on a bike, 45 minutes to 60 minutes, not too intense. And he strength trained, resistance trained 2 to 3 days a week, full body workouts. And it really made a huge difference. And we see this time in and time out with a lot of our clients. So some take-home messages today. Focusing on reducing your vices. And what is that? Do you drink 12 units of alcohol a day? A unit is a serving. So do you drink 12 beers a day? That's 1,300 calories. In order to burn 1 pound of body fat, you got to decrease 3,500 calories a day from your diet. So maybe just cut that in half. Are you eating too much at nighttime? Maybe just have a nice snack, such as a yogurt or rice cake with peanut butter, or maybe a Greek yogurt ice cream bar, something small. I feel it's okay to have 100, 150 calories before you go to bed. Are you skipping meals? It's really important to eat meals. What happens is when you skip meals, you end up eating more, and you're more likely to go past that Chick-fil-A drive-through or fast food and then overeat, and that's what contributes to that increase in body fat. Sweat the small stuff. 100 calories here, 100 calories there. You might not think it's a big deal, but it is. Just for instance, if you save $1 a day, you might think it's not enough, but over 10 years, you put it in the bank, compounding interest, it adds up. Same thing, if you save 100 calories a day, you can lose up to 10 pounds in a year, and that's not much. So you can do it through cutting your intake a little bit or exercising a little bit more. Plan and prepare. Just like if you had a doctor's appointment, you want to put exercise. So what I do is on Sundays, I look at my schedule and I put in 30 minutes of exercise here. When it's on paper, you're more likely to do it. And then, plan your meals. On Sunday, let's say you go to work, have your snacks ready, have your breakfast, ready in a section of the refrigerator, bring, food, sandwich or salad to work. And for dinner, have it in your mind what you're gonna have. And that is planning to succeed. A lot of times if you just wake up and you have no rhyme or reason, you're more likely to fall off the wagon. And then move more. And that's anything, dancing, cycling, yoga, anything to get your body moving can really make a big difference. I wanted to thank you for coming in today. Anytime talking about men's health, I love it because it is so challenging. Eating healthy is so challenging. It's one of the hardest things. That's why 7 out of 10 people are having a difficult time with it. If you want more information, there's some of our information. We have a studio on First Colonial in Virginia Beach in downtown Norfolk. We take insurance for nutrition counseling through Optima, Anthem, Cigna, Aetna, and Medicare. So it's covered 100%, no copays. So think about us, and I'll take any questions that you have. Thank you. Yes. Yes, we always recommend getting it from real food. So a lot of your whole grains, a lot of your fruits and vegetables, bran. So that would be the first. Now, if there's any GI issues, Crohn's or things like that, then Metamucil would be a good source to help, decrease constipation and, get that fiber in. Oh, hummus, yes, hummus is a great snack. The thing about hummus is it's often overeaten, and it could be caloric dense. So what I would do is, let's say for your 3 o'clock snack, I would get your veggies out, your raw carrots, cucumbers, broccoli, and spoon out about 4 tablespoons of hummus. And you can dip that in. Now they have the little serving sizes. So if you go to the store, they have the 150 calorie hummus serving size. So you can bring that to work, and it could be a great snack. It has protein, it has fiber. Yes? Yeah, so nuts are amazing. They're, however, they're the most overeaten food because just a fourth of a cup is a serving. And I don't know about you, but I had those Blue Diamond salt and vinegar nuts, and I ate the whole can. So I recommend the natural or the unsalted, and the reason for that is they're not as good as the salted and less sodium. So you want to, the best thing to do is I get the 100-calorie packs, and Blue Diamond, Emeralds have it. And with that is a serving size. So, 1.5 grams of nuts, especially walnut is the men's nut. The reason is it has 2.5 grams of ALAs, it's essential fatty acids for heart health. It also, there's a study showing that 30% increase in sperm quality from eating walnuts, and also your brain health. They're the best nut for brain health. I would say the second best would be almonds. And then you have pecans, pistachios, then you would see macadamia nuts, peanuts down the line. But, getting those 100-calorie packs, or it'd be cheaper just to get the big container and just, it's the size of your palm, put that in a bag and put those, just make a lot of bags with the 100-calorie servings. Yes? Yes, because you're combining some of that strength training with the cardiovascular training, so you're getting bang for your buck. Plus, we are busy as a society. We're one of the most busiest countries. So if you can do a workout in 20 or 30 minutes of higher intensity rather than an hour of slower intensity, it's great. I'd say the only caveat is if there's high injury, probably a little bit more higher injury risk. And then it's not for everybody. So if heart disease, things like that, I would start off at the slower rate and then gradually get into high intensity. But high intensity, full body workouts 3-4 times a week is amazing. Absolutely, absolutely. Aerobic exercise, obviously good for the heart. The problem is with it makes us hungry. And a lot of times I see people, they'll go for a walk for 2 hours and they'll think, well, I deserved, in walking, it's great for the heart and the joints, but if they're eating more, it's almost like a wash. So where strength training, you not only burn calories at that session, but your body is building lean muscle throughout the night and the morning, so you're burning additional calories for every pound of muscle you have. So I'd highly recommend it. Yes? So the elliptical is really, really mild on the knees. Your bike, your recumbent bike would be, that's the one where it's more horizontal. That would be great. The rower, that's really popular right now. There's not a direct pounding on it. that you would see from maybe walking or running. So those are good sources. And believe it or not, strength training does work the cardiovascular system. It can get anaerobic, but by doing your some of your strength training, that could definitely have a great effect on getting that cardiovascular system improved. Last question? Yes. So Lean Cuisine meals, I was a spokesman for them for 3 years, so not anymore, but when you're looking at under 300 calories, it's portion controlled. The only problem, and the company's working a lot to lower the sodium, but any of your frozen meals are gonna be a little higher in sodium, so if you do have high blood pressure, you just gotta be careful. So if there's 600 milligrams, you gotta look at the rest of your day and keep your sodium a little low. But I think they're great. They're not only Lean Cuisine, but Smart Ones and Healthy Choice. If you look, they're trying to reduce their sodium. All they do is they cook it there with a chef and they freeze it and they send them to you. And frozen food is obviously number one would be your whole foods, like cooking it fresh, but frozen is a very close second, and then it's canned foods. So I think I wouldn't make it, I wouldn't do all your meals, Lean Cuisine. Maybe if it's like 3 or 4 meals, have them in your freezer. If you don't have time to cook, awesome. Weight Watchers, the program, it's been out here for a long time. I think it's a great program. It's probably one of the better ones for longevity. So, on the point systems, a lot of people love it. So if it's something that works for you, definitely. Anything to improve health and improve exercise, we got to say it's successful. Mm-hmm. Great. I'll be here for a little bit after if you have any questions. One more, yep. So, if you have no blood pressure issues, I'd say great. And if you do, yes, again, sea salt does contain sodium. You'd have to look at some of the rest of your days. There's no difference in health benefits from sea salt for regular salt. Your Himalayan rock salt might have a little bit more minerals than your sea salt. But 1 ounce serving would be great. I recommend 1 to 1.5 ounces every single day having some nuts in your diet for the protein factor, for the fiber factor, for the phytonutrients, which can help to improve health. So, and that can be almond butter and peanut butter. Again, it's an overeaten food. You get a Triscuit and you put some peanut butter on it. 1 serving is a tablespoon of peanut butter, almond butter. So, when we're putting it on our sandwiches and our bagels, we can do 2 or 3 tablespoons. So we just got to be careful with that. Thank you.
That was great. I love that there were a bunch of questions and really engagement on the importance of this aspect of life. And I just really am so happy that we've been able to build this segment into the meeting here, and we're going to wrap it up really just on this idea of the integrated body. I mean, everything about our body is so important to our health, not just getting more pills from our doctor, but actually taking care of our bodies. And a big part of that, we're going to hear from next Aaron Glace, who's our Director of Physical Therapy for Urology Virginia, and is certified pelvic rehab practitioner, board certified in biofeedback and pelvic muscle dysfunction, and is going to speak to us about an area that I think is just fascinating, and is really the interaction really of our bodies and how that makes us feel. And so, Aaron, I'll turn it over to you.
Hello, everybody. Those were absolutely wonderful talks, and I'm so glad to follow both of them because I have the same points throughout my lecture as well. So I am a pelvic health physical therapist. So if you're not familiar with that, basically a quick description is that I work with men, women, and children at Urology of Virginia, which means that we specialize in the treatment of bladder, bowel, pelvic pain areas, and sexual function. So men's health, a lot of my male patients that I will see for sexual health concerns and bladder concerns. So my talk is going to focus on those issues. So what we're going to talk about today in my little talk here, first off, the picture over there is my husband and I recently went to Maine and went hiking in Acadia National Park. If you've not been there, it's absolutely beautiful. I highly recommend it. So one of our hikes, we reached kind of what we felt like was the end of the trail, but yet we were like halfway up the mountain. And we looked around and we just saw this, basically. So where do you go? And I'm using that as kind of an example, I think, for a lot of our patients with any type of pelvic health concerns. You kind of get buried or lost, like, what's the next step that I can take to help myself, right? So when we got to this point right here, neither one of us saw that little blue mark right there. That's the blaze. That on a trail, you follow the blaze. So we pretty much figured out that the trail was through those rocks, right? And again, another example of sometimes you need just a little bit of guidance or direction, and it might not be an easy trek that you're about to take, but hopefully it will be worth it. So I am going to talk about some things that people don't typically like to talk about, or at least, the first thing that you're going to bring up is, hey, doc, I'm having some problems with erectile dysfunction, or I have leakage, or I drip after I urinate. But we're going to talk about it today. So I hope that nobody has any problems with that, especially because we're going to be showing some anatomy pictures. So we're going to be seeing a lot of pelvises. And the reason that I do that is because I am a visual learner. And I really hope that after this talk, you all are able to take home some things that you can do for yourself. And in doing that, I want you to really visualize what I'm talking about. So the anatomy pictures that I'm going to show you are going to kind of layer where your pelvic floor is and what your pelvic floor does, okay? So we're going to show anatomy pictures. We're going to talk about the function of the pelvic floor. The function of the pelvic floor is very similar between men and women. So any women in the audience, you'll gain some benefit from this as well. We're going to talk about what can go wrong with your pelvic floor and what you can do. Because I really, like I said, I want you all to leave today with some tips and tricks for pelvic floor. So here's our first anatomy. So with this picture, what I want to kind of reference is the fact that your pelvic floor is part of your body. It's part of your system. So another thing that I'd like to do throughout my talk is just kind of give you little hints about what we will look at if you come to see pelvic floor physical therapist. So we're going to look at your pelvic floor, but your pelvic floor is connected to your pelvis, which is connected to your spine. So it's all together. So we would, if you were referred to physical therapy, look at all of those things. So the pelvic floor muscles are a major part of your core stability. It's an often underlooked at part of your core stability, but we will have other physical therapists in the area that are aware of that interaction and will refer patients to us who have had chronic back pain or other types of pain, and we'll come to determine that it's actually the pelvic floor that's the problem. Your pelvic floor muscles definitely control bowel, your ability to maintain your bowels inside as well as to release. Same thing with the bladder and sexual. We will be focusing today more on the bladder and sexual functions. So again, the pelvic floor muscles are low back and pelvic stabilizers. They work with other muscles to create stability and balance. And I think just following up on Jim's talk, general fitness can actually very much impact your pelvic floor function. So we're all saying the same thing. Thus far, all of our talks are really driving home the same point. Stay as active as you possibly can. So in this anatomy picture, you see that we're kind of filling in the bottom of the pelvis. So your pelvic floor is really a large group of muscles that we're all sitting on right now. And if you kind of sit up straight and kind of wobble side to side on your sits bones, you're sitting right on those muscles. And you can see that they extend from the tailbone all the way forward. So let's look at the anatomy picture first. So we looked at them from the top. Now looking from the bottom, you see that they extend all the way forward towards the base of that penis, okay? Again, re-emphasizing what the muscles do, they do maintain bladder closure to prevent incontinence. So they help you to, again, keep your urine inside. It's not leaking urine. They relax or release to allow good bladder emptying. That's very important. They act to inhibit initial bladder urges. So you can actually use those muscles to help stop urgency or to help make it to the restroom if you feel a very strong urge and are worried you're not going to get there. Similar action for bowels. These muscles also help to maintain erection and to prevent premature ejaculation. So that's important. They help. It's not the only thing that helps with erection and ejaculation, but they are a key player in those two functions. And again, the muscles also need to be able to relax to allow blood flow into the shaft of the penis for erection. So those muscles have to work both ways, contract and relax. So what can go wrong? You can have weakness in those muscles. You can also have tightness or tension in the muscles. That's the often overlooked kind of phenomena. You can read all about doing Kegels, and we'll talk about Kegels, but we don't often talk about actually releasing the muscles. And I've found in my years of practice that that is often the driving factor. It's not so much that the muscles are weak, it's that people kind of grip those muscles and don't let go. And that can create a lot of problems with pain and dysfunction. So what happens with that? You have a loss of bladder control. So that might be your urge incontinence where, ooh, I gotta go to the bathroom, and you start running and you just can't make it. You may have post-void dribble, which is that leakage after urination, and we'll talk a little bit more about just some simple things that you can do to hopefully help correct that. But that's often I will see men who have that post-void dribble. You can have frequency of urination with the weakness or the tightness. You can have pelvic pain, and you can have sexual dysfunction. It can contribute, these muscles dysfunction can contribute to diminished erection, premature ejaculation, pain, and you can also have constipation. So Dr. Arnold Kegel was a physician in the 1940s who did some research with women post-pregnancy. And basically he looked at, in a scientific way, if we exercise these muscles in women after they have a baby, will they have improvements in bladder control and sexual function? And yes, they do. So it's great. So since 1940s, we referred to these exercises of the pelvic floor muscles as Kegels, and oftentimes people will say, oh yeah, I know the Kegel, isn't that the female exercise? Isn't that the women muscles? Well, women have those muscles, but you guys have those muscles as well. So we definitely want, again, on my anatomy pictures, to familiarize you with where those muscles are. So if you do your pelvic floor muscle exercises or Kegel exercises, you can obviously increase the strength of your pelvic floor. You can increase blood supply and nerve supply to the pelvic region, which helps with sensation, helps with sexual function for men and women. You can have prevention and treatment of urinary incontinence, and again, improve sexual function, response and function, including sensation, because those muscles play a key role in sensation of orgasm. Oops. Okay. So how to do a Kegel, right? That's the question. That is definitely the question. This is a group of muscles that you can't really see, right? So how do I contract and relax? So if you have your camera and you want to take a picture, feel free. This is all over the internet, I'm sure. But basically, you're going to find a comfortable position. So if you were a patient coming in, we would assess you thoroughly about what is going to be your best position. We use EMG biofeedback. We put very comfortable little stickers kind of on the anal area, and we are then able to see a picture, a graphical image of what your muscles are doing, just a graph. But if you're not coming in to see us, and I'm just going to verbally instruct you how to do a Kegel, you're basically going to find the comfortable position. That can be sitting, that can be lying down. Typically, it's easier to start in one of those positions. You're going to relax and take a deep breath. The first thing I want you to focus on is relaxing your whole body. If you go to try to isolate the pelvic floor muscle and you're tense everywhere, your body isn't really going to be able to kind of key in. So again, thinking back to those anatomy pictures, where are those muscles? They're between your two sits bones. You're sitting. You can feel those muscles there. So if you're sitting in a chair, if you're going to contract, you're going to pull up and away from the chair. And then equally important, you're going to drop down into the chair. So that full range of motion, and that is key. It's not just contracting, it has to be the release as well. So again, this is one of the take-homes that I hope all of you will kind of go home and maybe practice. Maybe you're practicing right now. The beauty of a Kegel is, I don't know, right? You don't have to change your clothes. You don't have to go to the gym. You can do your Kegels pretty much anywhere, but it does require some thought, especially in the beginning. So for men, there's actually some studies that show the words that are the most helpful to elicit a true Kegel in a man is that it's like you're trying to stop the flow of urine, or you're trying to pull in the shaft of the penis, okay, inward. You want to get the contraction all the way from the tailbone to that base of the penis, so you feel all that pulling in and dropping. So the words for women, we talk about, just because I have some women here, gotta include you. We're talking about closing and lifting the vagina area. So those are the words that have been studied, and I would agree that those words often help in practice. So you're going to begin with just a few second contraction, 2 to 3 seconds, work up to about a 5-second hold. You want to keep breathing, you're not straining. If you're feeling other parts of your body really pull in too tightly, then maybe you want to back off a little bit and stop trying so hard and really kind of focusing. Those muscles work with the body, they work with the total system, but they also need to be trained in isolation. So you want to be able to get as much sensation and feeling as possible. So relax and release. You're going to relax for a little bit longer, especially when you first start doing your Kegel exercises. And you begin with 10 to 25 repetitions 2 to 3 times daily. So that's a big range, right? But again, if you came in to see us in practice, we would be able to assess, say, well, you can do this many, and this is where we want to start. It is an exercise of a muscle, so like any other muscle, you want to kind of grade up that activity as you get stronger and stronger. We do a little bit of things to help overload. You can change positions as you go along. So a Kegel, which seems so simple, can actually be quite a complex exercise program, depending on what your needs are. So let's kind of go into bladder and some things that you guys can do to help rein in that angry bladder. So if you're having frequency urgency, getting up at night, we've already referenced the post-void leakage, or difficulty emptying your bladder. I do want to make note that when we're talking about bladder dysfunction, or really sexual dysfunction as well, this is part of the picture. We're all here today to kind of give you those blazes and give you some tips and tricks towards getting to the end or feeling better. And so I do work with wonderful urologists, and the urologists will often identify some things that perhaps wouldn't be made better by pelvic floor exercises. It's never going to hurt to do pelvic floor exercises. It's only going to help for sure. But it might not be the only thing going on. So I just want to point out that this isn't, obviously these aren't the end-all be-all, but they can be very, very effective and often the missing kind of link to getting better. So this anatomy picture, I've highlighted the urethra. So what we're looking at there is the bladder kind of and half of the pelvic floor. So I took off half of the pelvis so you can kind of looking in sideways. So you have the bladder, and then I made the urethra blue because I want you to see the angle of that urethra. And do you see how the pelvic floor muscles are sitting right up underneath that? So that makes sense that if those muscles are too tense, you can create some problems with emptying your bladder, right? It also, if those muscles are too tense or tight, you can have pain in that region. Because if you have a muscle spasm anywhere in your body, you can have pain. And so unfortunately, if those muscles are tight or tense, you might feel that pain in the shaft of the penis. You might feel that pain in the testicle. And often men at that point will think, oh, there's something wrong with my penis or my testicles or my bladder, when in fact it could be a musculoskeletal issue. So just being aware of the fact that there's other things down there and it is all connected. So tips and tricks for a healthy bladder. Drink more water, right? Oftentimes if you have frequency or urgency, what's the first thing that goes? Well, I'll just drink less, right? And that can be detrimental to both overall physical health, but it's also not good for your bladder. And that just makes your bladder kind of angry like we saw earlier. So don't cut back on water intake. Even though it doesn't make sense, actually flushing your bladder and having good water intake and limiting your number of bladder irritants, such as coffee and soda, things like that, can actually help you to feel like you have to go less frequently. So don't strain to urinate. If you're pushing to urinate or trying to go really fast, chances are that those pelvic floor muscles are actually contracting rather than releasing. And so if they're contracting, they're going to close off. It's going to kind of irritate the whole system. So take a deep breath, relax to urinate. Sometimes that's going to also feel like your abdominal muscles, because there is that interconnection, release. If you feel, men or women, that you're pushing and your belly muscles are pulling in during urination, think about letting go of those belly muscles and kind of dropping through that pelvic floor. You might actually empty more completely. You're going to be less irritation to the system, and so you won't have to go as often. That's the hope, okay? So relax the pelvic floor during urination. So if you're having that post-void dribble, right, that at the end of urination, men get so frustrated by that, and I completely understand that. You think you're done, you do some squeezes at the end, and you're like, I know I'm done. You walk away, and you have a dime size, a quarter size, or even a little bit more kind of leakage afterwards. So here's a tip. What you want to think about is that angle of that urethra. And so I've done a lot of EMG testing with men where we hook them up and we actually see what those muscles do during urination. And oftentimes at the end, what is kind of a standard for a lot of men is just to contract the muscles thinking that they're pushing out, but they never let go again. So you're just pulling in, so you're kind of pushing up. But if you're relaxed during urination, give yourself a moment, and then you do one strong Kegel, and you kind of maybe push if there's any urine kind of that has gotten perhaps stuck in that area or hasn't come completely out. You push it out, but then you relax through the pelvic floor. Give yourself another 10 seconds perhaps with that release through the abdomen and through the pelvic floor. You might stop some of that leakage. When you're walking away from the bathroom, that's when you can do those kind of few Kegels a little more strongly to kind of, whatever's left, just kind of close off that sphincter. Okay? So, urgency. You're sitting here right now, I'm done talking, you had some coffee, you're like, oh boy, I'm not gonna make it to the bathroom, men or women. After this talk, I gotta run, or I have to leave a little bit early ahead of everybody else because I gotta be the first person there. Before you get up, do a few Kegels, take a deep breath, relax, distract your brain. I always say sing a song or something on the way to the bathroom, because your brain will start to prepare you to go to the bathroom when you're on the way, right? And so that's key in the door syndrome. That's like, oh, I can't make it to the bathroom, right? So these things really, really, really work. So now we're going to talk about sexual function. okay, and how the pelvic floor can play a role for men in sexual function, okay? So in this anatomy picture, what we're looking at in the other anatomy picture prior for bladder, I highlighted the urethra. So what I'm highlighting here is the vascular supply. So with erection, what happens is the shaft of the penis, shaft of the penis fills with blood, okay? And so we need good blood flow in and out of the shaft of the penis. So again, that arrow shows where are those muscles. If those muscles are weak, you can have diminished erections because once the blood is in, the muscles help to hold it in there. So if they're weak, you can have diminished erections. And you can have an inability to sustain erection as long as desired, okay? Premature ejaculation is all relative to how long you want to maintain the erection, right? So if you have too much tension in those muscles, you can have the same thing. And you can also sometimes have pain with erection or ejaculations, and that clearly isn't fun or desirable, right? So again, movement of those pelvic floor muscles can be very helpful for both getting an erection and sustaining erection. So if you imagine prior to intimacy or as you're building to the act of intercourse or penetrative intercourse or just erection and ejaculation, you're relaxing. So this is more where you're like, okay, let me find some breath, let me relax through that area. And then as you have an erection, actually being able to contract those muscles, that might be a time to really pull in that pelvic floor activity that we've talked about doing the Kegel exercises. That can help. And the stronger those muscles are, the more likely they're going to work more naturally. So as you don't have to think about it as much. Just like any exercise or any motor plan that you do throughout the day. If I am learning to play a game of tennis, at first I have to really focus on it. But after a while, it becomes more natural. And the same thing can happen with pelvic floor exercises. So what to do? I'm emphasizing those first two talks. I don't really have to say much about that. Eat well. Heart health equals penis health, right? So it's vascular supply, it's muscle supply. So I think a lot of people have some different motivations in life, and so sometimes intimacy and sexuality can be a real big driver. So if the driver for you is intimacy and sexual health, and that motivates you to take better care of yourself, all the things that the first two talks were about applies to this as well. Pelvic floor exercises, and I put Kegels with care because it's not just about tightening, it's also about relaxing and releasing those muscles equally, if not more important. Relaxation, I absolutely loved the talks again about how mindfulness and relaxation can play a huge role in so many of our dysfunctions. So ask for help. So I hope that a lot of you will have learned a little bit about some ways that you can apply pelvic health and that you'll be able to take these tips and tricks, and if you just have some minor problems, be like, okay, you know, in a little while of working on this, you're doing well and you've gained some control. If not, Urology of Virginia, we've got a great group of physicians that can assess. We also have a great group of physical therapists that can help you. Physical therapy for pelvic health is very different than physical therapy for an orthopedic problem. If you've had like back care or post-surgical rehab, that's often 2 to 3 times a week, and you go for a definitive period of time. Pelvic health is very different. You come in, we have a private treatment room. We're not in a gym, so there's nothing to be, worried about. And we typically will see our patients maybe once a week. Often you'll come in, and depending on what the issue is, we'll assess and we'll get a lot done. We have an hour for you that first visit. We'll get a lot done, and I'll say, you know what, you're doing great. Let me see you back in a month, and we'll see how your program is going. So I just want you to be aware that it's not like a major time commitment. So here we are. We made it through all the little blazes and all the rocks. And so sometimes it is worth the journey and the kind of getting through some of those areas you're not quite sure where to go. And I hope that today you guys are learning some things and getting some guidance when you're not quite sure where to go. So I couldn't resist that. Stay safe. And we're saying that about a lot of things these days. So I liked that last slide. I'm happy to take any questions. That's a great question. So the question was, if you're sitting, will that help to completely empty? So I highly recommend for my female patients not to hover, or to hover very rarely. For my male patients, in some cases, sitting will help. Yeah, so it's pretty individual with the patient or the male, so I will kind of talk about that and give some clues. Obviously, it's worth a shot for sure. So referral to get to Urology or Virginia Physical Therapy, it can clearly be through one of our physicians, but we can also take referrals from your primary care provider. We do require referrals. So there is direct access for physical therapy, but we're a very specialized practice, and so we go ahead and request a medical provider referral first. So PRP injections, or can you say that again? Kegel. Oh, Kegel throne. So I'm not familiar with Kegel throne. My guess is that it's some type of electrical stimulation unit. So you can use what's called electrical stimulation or neuromodulation on any part of your body to help facilitate motor unit contraction so that you get a contraction. You know, if you're going to put it on your biceps, you can put a couple electrodes and it facilitates a contraction. I think that in terms of for the pelvic floor, so my preference would be, if you're considering something like that, it might be worth getting an assessment from a physical therapist, a pelvic floor physical therapist, because you might not need it, and sometimes they can be helpful for some specific patients. So probably kind of mixed. It would depend on also what your issue that you were looking for, you know, why you wanted to use that. Mm-hmm. So problems with erection, I'm going to say your first step is going to be to apply all of these things that we've talked about today, health and well-being. You can certainly try the Kegel exercises, and then again, that kind of tips about, like, can you relax to allow erection? Can you build that muscle strength? And then, you know, there's going to be other talks for sure talking about testosterone and medications and things like that. So definitely talk to the doctor. Doctors at Urology of Virginia, we work with them, so if they feel that physical therapy would be a good complement to you, they will certainly let you know, and you can certainly ask about that as well. All right, wonderful. Thank you so much.
Okay, next you're stuck with me. And I'm going to talk about testosterone, which is titled Fact versus Fiction because I think in popular culture today, it is such a discussed topic. And I think several people this morning have even alluded to that in conversations and up on the stage. And so I think it's something that absolutely needs to be discussed, right? You're hearing about it everywhere you look. So what is it? Is it something that's good for us, something that we need? Yes. Is it something that gets abused? And you know, these before and after pictures are pretty fascinating, really, whether or not testosterone's to blame, depends on who you ask. But if you watch TV, read the newspaper, or listen to the radio, they would tell you that everyone should be on testosterone, right? It's big business in this country right now, and it's quite expensive. There's a lot of entrepreneurs out there setting up shop, marketing extensively to you about this and charging a lot of money to folks, which I really hate to see, because for those that need testosterone, it's something that's covered by your insurance. You've worked hard for a long time to have medical insurance to cover the things you need, and if this is one of the things you need, it should be covered and very inexpensive. And so we'll talk about that and who needs it, what it does, what the expectation should be. Testosterone prescriptions are going up. This is actually fairly old data, but the trend has continued in newer data that the number of prescriptions are going up, and it's going up for all decades of life, for younger men as well as older men. All are seeing a trend in increased number of prescriptions. So what is it? Well, it's an important male sex hormone. It's important for both mental and physical well-being, involved in development, muscular strength, fertility, and sex drive or libido. You do not have to memorize the chemical formula there on the right. So what are the symptoms? Well, the ones that are really linked, that we know without question are linked to testosterone, would be the sex drive or libido. And these are linked to if you were to have low testosterone. So if you have low testosterone, you'd have lower sex drive libido. You could have loss of lean muscle mass. You could feel tired, fatigue. You could have a decrease in vitality, and then weight gain and obesity. But what about things that may be linked? So the data a little less firm, but certainly could be linked to testosterone deficiency would be things like just lower endurance and physical strength, poor memory, trouble with words and word finding, poor focus, symptoms of depression and mood instability. I do believe that is a very true point there. Not performing as well at work, and then more sexual dysfunction. But I put this up just to make the point that it really is a head-to-toe problem. Maybe not toe, but close. It absolutely affects mental well-being and health, as well as many aspects of your endocrine system, musculoskeletal system, overall function of the body for those with testosterone deficiency. It really is a head-to-toe problem. And it's common. It's common, and it's also seldom addressed. So we know that it is common in across decades of life. It does increase as you go through the decades of life. Up into the 70s and 80s, you'll see an increase in those that are measuring low on their blood test. And so we think 35 to 50% of men may have testosterone deficiency, but again, this is a little bit older data. Only 5 to 35% are actually seeking treatment and being treated for it. Why does it happen? And let's talk about that specifically in the context of why are we seeing it so much more now than maybe in the past? Well, the aging process does have some impact on it, but really it is diabetes, obesity, and those two, if we just stop and think about those are becoming so much more prevalent in our country and you see that the incidence of testosterone deficiency tracking right along with that. There's really an incredible interplay between all the things that we've just talked about this morning: your heart health, your cardiovascular fitness, your nutrition status, to feed back and cause testosterone deficiency. Through the mechanisms of diabetes and obesity, obviously beyond the scope of our discussion this morning, but those are really the driving causes, I think, that we're seeing in America today. Obstructive sleep apnea, also very common. Less commonly, chemotherapy or radiation, certain medication uses, which are a profound cause, and certainly it's really opioid use, antidepressant use, they can cause a profound change in testosterone, which only compounds then a lot of times the reasons the men are on those medicines, right? And so we do try to pick up on that. Certain infections and autoimmune diseases as well. How do we diagnose it? Well, it's really by a blood test as well as an understanding of your symptoms, but blood tests for your testosterone levels should be in the morning. The testosterone changes throughout the day, and the numbers that are considered normal, so if you hear somebody say a normal testosterone is this range, that's in that early morning test time. And if you check it at the end of the day, it's going to probably be lower, because there's a natural, as we all have circadian rhythms, we have a peak in the morning that gradually decreases through the day, increases back through the night, and is high in the morning again. And so it does depend on the time of day. You're going to get different readings, but the testing of the blood levels is important. A lot of times we'll test other hormone levels that are the signaling molecules for testosterone, as well as your red blood cell counts. It's linked to anemia. On the physical exam, we're going to want to understand, again, testicular volume and size, as well as a full medical history of your symptoms, as we talked about just a moment ago. So if you have testosterone deficiency, now what? We all, I think, will say, if we're honest, that we feel like Homer sometimes, right? We're worn out, exhausted by life. The American lifestyle and diet are going to lead us to feel like this. But, is it all just the fault of testosterone? I think men want that. It's an easy fix, right? Everybody wants to just, hey, give me a pill or a shot or a cream to fix everything. I think the stuff that's harder to do is the stuff that Dr. Talreja and Jim talked about, as well as Aaron, about actually taking care of our bodies, thinking about the whole integrated person, and what goes in, to the body, and what comes out. Are we exercising, et cetera? But, this is a real thing, and it is a real component to that. And in fact, I will say that, I think it's a bit of a tragedy that men may live a lifestyle, get into a place where they have testosterone deficiency, and then they go to their primary care doctor and they say, "Doc, I got this, and this symptom. What do I need to do?" And the doctor says, "Well, you need to get yourself in shape. You need to exercise. You need to, and those are all good things, as we've just heard. But I think the reality is, if the spiral has occurred to where the testosterone is now low, you're behind the eight ball, so to speak. You don't have the energy, you don't have the stamina, you don't have the ability to build the lean muscle mass, to get out and do the exercise, to lose the weight, to build the muscle, to get your physiology back to where it needs to be. And so I think testosterone replacement is an important part of that. But again, in conjunction with the bigger picture, but definitely a key piece. So we can replace testosterone in a number of ways. We want to restore the body's testosterone into the normal range. We can do that, I believe, and I don't try to make it too high. I think we try to control the timing and interval of dosing so that we're keeping you in that normal range. I've yet to have anybody really explain to me why that is risky, and we'll talk a little about the risks of testosterone therapy. But our goal is not to be too high. Our goal is not to have you stay too low. We want you in the normal range where other men of your age group would be lucky enough to fall, and we can accomplish that in a number of ways. When you talk about risk, now if you take a blood pressure medicine, that's not something that your body's ever seen. That was made in a chemistry lab somewhere, and you're going to see it for the first time when you take that pill. And so you have to talk about, well, what are the risks of that? Because this is a chemical that your body doesn't normally have, and we're going to put it in, and what's going to happen? It's a little bit different with testosterone, right? Because you already have it. We're just saying you don't have enough, and we want to give you more. And so it's a little bit different conversation about not what are the risks of you having this substance in your body, because you already have it, but what are the risks of it staying low where it is? What are the risks of it being up high if we replace it? And that's really more the concept of that conversation. It's not an artificial compound that your body's never seen before. We can replace it by injections, by topical creams and gels, by implanted pellets, by nasal spray, and now after the last one to come to market actually of all those is a pill, which we have now as well. And so this is a list that we'll go through. And the key is that these are not expensive. No form of testosterone replacement should be expensive at all, and certainly with appropriate insurance coverage. So the injections are either short-acting or long-acting injections. I like to dose injections weekly, and I actually like to do it subcutaneously mostly, so that it can be given just the way folks give insulin. So you just kind of pinch a little bit of skin and the fat underneath, and you're just getting it in there. You're not having to use a big needle and get into the muscle the way you've probably had for some injections through your life that's more painful, and you don't want to be doing that all the time, ideally. So I feel like we get better adherence and interest in doing it this way when we do the subcutaneous injections. So that's my preference for folks that want to do injections. We do teach you how to do it yourself. It's very, very simple. There's a long-acting injection that's given every 10 weeks. You do have to come to the office for that one, but at least you're only showing up 4 times a year for that. The topical gels and creams, those are given daily. Every morning you wake up, you rub it on. It is absorbed through the skin. There's some variability in that. Not everyone absorbs it quite the same. There are some concerns over transferring it to others. You don't want it to rub off on your loved ones. So that's something to consider about that mode, but obviously doesn't involve having to inject yourself. Testosterone pellets are a way that I do really like. You come to the office, we numb up a spot kind of on the love handles, slide a special needle in that we can drop these pellets in through, and they actually then slowly dissolve for somewhere around 4 to 6 months, and really you're not thinking about or doing anything in that time besides living life. And so I do really like that. It allows you to kind of move on with life and not have to be thinking about this or doing anything, and the numbers that we get are great. Gets good levels and a very slow kind of decline on that. Oral testosterone is really the newest thing, and it is twice daily dosing, so it does have to be given twice a day. But believe it or not, the chemistry side of how to be able to deliver testosterone in a pill form, have it absorbed appropriately without being toxic to the body, was actually very hard to work out, and has really just come about in the last year or two. It's still currently like a second-line therapy, so the insurances aren't wanting to pay for it up front. They want you to potentially try something else, depending on your insurance, of course. But it is a little bit harder to get on if you're just starting testosterone for the first time. And what I like to point out here is just thinking about the cycle time. Again, my goal is to have you in the normal physiologic range where you're living as close to a normal level as possible all the time. And so this just kind of shows in my kind of crummy graphics here that if you do the topical, again, you have to do it every single day. So you're going to put it on in the morning, get your good high levels. It's going to drop down throughout the day, and then you'll put it on again the next morning, which is actually very much the natural physiology, as we said. It does kind of naturally go on that cycle for men. The short-acting injections, more of a weekly kind of milder up and down. The longer-acting injections, again, over 10 weeks, you're going to see a more gradual rise and fall of the values. And then the pellets on that 4 to 6 month, you have a very gradual decline back to the time that you need your next appointment. And what I hate to see, and I feel like is the most common way that I see folks come in, both from primary care, from endocrinology, et cetera, and it's actually not their fault. It's the way testosterone was approved in the 1930s, was every 2-week dosing. So it's actually a very significant dose that you inject in every 2 weeks. So you get a big spike that's too high, and you have to get a pretty big dose for it to last that long. So you get a big spike that's too high, and then it drops down, and probably the last few days before your next injection, you're too low. And so you have this roller coaster effect, I call it. And so that, to me, is not the goal, right? That's not natural physiology, which is our goal. So we try to get you on a way that's going to keep you as close to normal and not leave you feeling like you're on that roller coaster with the injections. The goals, again, to undo all of those issues that the deficiency in the first place caused. So improving energy levels, improving libido, decreasing fat, helping you build lean muscle, improving mental clarity, improving mood, improving sexual function, and improving insulin sensitivity, which is another one that we don't have time for today, but I think for the diabetics in the room or listening online, understanding your testosterone levels and seeking replacement if it's appropriate are incredibly important factors to improving your diabetic control and improving your life. On the issue of mood, I've seen men come in on multiple antidepressants or anti-anxiety medications, have their testosterone replaced, able to get off of those medicines because they're just their mood, their mental clarity, their feeling of vitality, all those things had been restored. Not every person, of course, that comes in on those meds is going to get that result, but I've seen it, and it is a real thing. And it takes time, and so this just shows over the course of 12 months when you would expect to see each of these things kind of set in. And so you're going to see perhaps like the early impact on libido, and then start to see energy level and muscle gain eventually. So it's a process, and we're not going to go through in detail, but it is not all going to happen overnight. We do encourage then frequent reassessments of your symptoms and your response to treatments. We're going to check your levels, make sure they're not too high or low. We're going to check other hormone levels, and especially your red blood cell counts, your liver function tests. We don't really need to do anymore. All the mechanisms now don't really require that. It's very safe. And then also make sure that you're pairing healthy lifestyle changes, as has been discussed so far this morning, with the testosterone replacement. So the way we do it, we'll check 4 to 6 weeks later. Then we'll check 4 months after that, and then nearly every 6 months to annually as far as in-person visits. So once you get on therapy and are treated adequately, we don't need necessarily frequent follow-ups. Is it safe? So again, I mentioned earlier, the areas that have been somewhat debated over the years are the impact of testosterone on cardiovascular health, on prostate health, on sleep apnea, on what's called venous thrombosis or DVT, and then on fertility. And again, I don't have time to go into depth on this, but I'm happy to answer any questions you have on these issues. But there is no evidence linking testosterone therapy to prostate cancer. In fact, I really believe we've seen some data come out now, and I think that where we're going with this field is understanding that low testosterone is riskier for prostate cancer than elevated testosterone. And the details, again, we can discuss offline, but that is, I think, now pretty firmly understood. There's no strong evidence linking testosterone therapy to increase in vein clots, and at this time, there's no strong evidence that testosterone therapy either increases or decreases the risk of cardiovascular events. I would personally feel and have a lot of data I can show you that it actually decreases cardiovascular events, but there has been enough sort of conflicting studies, even though I think those studies were flawed, that the formal statement from national organizations is that we just don't know one way or the other. But I think if you look at the data, you could really see that there is a pretty clear trend there. Just as a side note here, sperm counts are low or undetectable in men that are on testosterone therapy. The body's smart enough to know that if you're getting something from the outside, why bother making it? And so the testicle makes testosterone and it makes sperm. And so if we're giving you testosterone, your body says, okay, turn off the factory, and that shuts down both testosterone production and sperm production. And so men who are on testosterone will have a lower undetectable sperm count. And I'm a little bit shocked at times when younger men have come in on testosterone and I say, well, do you desire future fertility? Anybody talk to you about the impact of this? And they haven't heard. And nobody mentioned when they started them on testosterone that it does have an impact. Now, if you turn the factory off, you can turn it back on, and we can rescue, if you want to call it that, fertility in men who have been on testosterone in the past. So it's not they haven't burn any bridges, so to speak, but it's just a point that deserves to be made, that you should always consider whether you want future fertility and what timeline that would be before you're going to initiate testosterone therapy. So I'll stop there. I actually have no idea if I went over time or, but I will stop for any questions. And I brought along a lot of my data if I need to reference it for anything. So feel free to ask, and I'll pull it up if I can. Look, I'll stop on this slide and just show you. This is men. I can't really see it well enough, but the green were men that were given testosterone. These are diabetic men who had low testosterone. And the men in green were given testosterone, and the men on the gray line were not given testosterone. They just maintained where they were at, and they tracked them over 10 years. And you can see this is on insulin dose. Oh, there's a laser pointer here. Insulin dose. So the men that were treated with testosterone saw a decrease in their daily insulin dose of, I think, 15 units, whereas the men that did not get testosterone treatment had an increase in their insulin dose over that time. Isn't that fascinating impact on diabetes? So any questions? Yes, ma'am. Yeah. Yeah. So the question is about insurance coverage and about the struggle to get it covered. It should be covered if it's appropriate, and I don't really know what to say. I mean, yes, if you need to come and see me, I'm happy to help with that. I don't know why. I don't know what the particular hang-up would be on that. It really shouldn't be, and I don't, again, if it's appropriate, and family doctors usually aren't willing to start it if it's not deemed appropriate by the numbers and everything, it should be covered. And I feel like we can fix that for you if we need to. Yeah, that's the other thing. I mean, when you've been on it for quite a while, the idea that they wouldn't support you maintaining it, I don't really, we can talk about it. I don't, yeah. Does testosterone affect PSA? It may, and if your testosterone's low, okay, when you come into the doctor for the first time, your PSA is going to be artificially suppressed. So that PSA number that you're checking isn't really your true PSA when your testosterone is replaced. So when you replace your testosterone, and we actually think there's a cut point for this, if it's below 250 when you come in and you're diagnosed, if your testosterone is below 250, when you replace that and you're treated, then we would expect, and in fact be surprised if it didn't, have a little bit of a rise in your PSA, because all that's doing is taking your PSA from its artificially suppressed value up to where it ought to be. And yeah, well, once you're on the testosterone therapy and your PSA rises to what it actually should be, that true value, then you're going to watch it out from there. If it ever goes up, we work that up. I mean, that, again, as you're going to hear from Dr. Sobel, there's a lot of reasons for that, not necessarily prostate cancer at all, and so we can work that out. Yes. Yes, Dr. Sobel. The question is PSA being bad, is it when it rises, is that bad, or is it just a marker that we need to look into like any other blood test? You know, I don't know the answer to that, and I feel like there's going to be a talk here in a few minutes that really might have the key to that question that you should probably stick around for. But the answer is no, of course, it's not. And just to your point, it's just a number. Yeah. So just a real quick point on testosterone in the prostate. So if the prostate is a plant, testosterone is water for the plant. Okay, and so if you're drastically low and you're in drought conditions, okay, then the plant is going to wither, right? Your PSA will drop, and you'll be like the kind of plant down here on the left. As we replace your testosterone, you're going to bring that plant back into a healthy condition, and that may involve a little bit of a PSA rise if you were artificially suppressed, basically, to begin with. But the key to this, actually, and the reason that this slide is on here is actually because of that idea, well, if I treat testosterone and actually get it up into the higher ranges, isn't that going to cause prostate cancer? And I think the idea here is, think about it with your grass, right? I mean, if you don't water your grass and there's a drought, it's going to turn brown and it's not really going to grow very well. If you water it, the expected and reasonable amount, you'll get it. It'll grow and it'll be green and it'll be pretty. If you flood your yard, it's not going to grow anymore, right? You can't overwater and expect better growth. It's just there's a limit. When it's healthy, it's growing at the rate that it's supposed to, and that's the same way that the prostate behaves with testosterone. Yes, sir. Yes, we are, yeah. Yes, I am, yes. We are in the 225 building, yeah, at Clearfield. Mm-hmm. Yes. Was that a question back there? Oh, yes, yes, sir. I'm sorry, I couldn't really hear you. Langston, I think it is. Yes, sir.
So when you say that testosterone therapy after diagnosis is something that's going to be done your entire life, like a Bible?
Yeah. That's a good question. Is if testosterone deficiency is diagnosed and you're initiated on testosterone therapy, is that something that's lifelong? And yes, the answer is essentially yes. I think there's some times where, again, we talked about obesity, diabetes, et cetera. If men are able to really make a significant impact, lose weight, really change their health, then again, that vicious cycle, we may be able to break the cycle and then actually taper off of the testosterone. But otherwise, yes, the answer is that it is something that you have to continue to take if you want the benefit of it, right? You can't just take it for a period of time, it fix you, and you go on with a high level, generally speaking. You're going to have to continue taking it if you want that benefit. Yeah, is there benefits to lowering cholesterol? I think it's the improvement in the HDL that is the beneficial aspect of it. Now, it also remodels cardiac plaque, and so this is where you kind of get into the weeds on some of the cardiovascular stuff. Where there was a study that showed that it increased the size of plaques in the coronary vessels, right? So then they said, oh, testosterone's bad. But then the reality was they did some pretty fancy analysis through MRI, I believe, of those plaques and found that actually they stabilized and they were less likely to rupture, which is what a heart attack is. A heart attack is when one of those plaques ruptures and causes an event that occludes the vessel. So whether you're talking about the impact on cholesterol levels, the impact on specifically the HDL side, or even down to what is it doing to atherosclerotic disease, I think that there is potentially some benefit there, but it does fall into that technically controversial range. Anything else? Okay, great. I don't have the agenda in front of me. Oh, thank you. Thank you, sir. Thank you. All right, we're going to take a quick break. I think we probably ran into the break time a little bit, but I want to give you a chance to stretch your legs. Please visit the sponsors, grab a snack or a coffee here. And then the one other thing that we have, and I failed to mention earlier, but we have the ability to get you a PSA test. So if you are here and you lack access either to insurance or a doctor that can order that for you and you would like to know your PSA, we're going to still be talking here over the next hour about the prostate, about PSA. But if that's something that you don't know your number, you haven't had checked, and you don't think you'd have easy access to get it checked, we can help do that through the generosity of Sentara, through Virginia Beach General Hospital. We have a voucher for you to do that, and you would see the registration desk, see Celeste at the registration desk, and she can do that for you, okay? So we'll keep rolling here, and I want to introduce Dr. Sobel, who is one of the urologists at Urology Virginia, has added an unbelievable wealth of technical expertise and knowledge to our group over the last couple of years, and just passionate about prostate health and surgery, and incredibly knowledgeable. So I just want to go ahead and have him join us up here. He came to us from the Mayo Clinic, where he did his residency training as well as a fellowship in minimally invasive surgery. And he is going to tell us everything that we ever want to know about the prostate.
All right. Well, I feel honored to be able to talk about the prostate because it's such an important thing and topic that so many men think about. So what is the prostate? The prostate is a small organ that you're basically voiding through every time you urinate. It doesn't, a lot of people think about the prostate as this thing that surrounds the urethra tube, but there is no actual urethra tube that runs through the prostate. It's basically bladder and then a crevice or a channel that runs through the prostate, and then after that, you'll have a tube that starts the urethra. You can see that there. And what does it do? Well, I think for what it does, it actually causes a lot more harm than good. I mean, it's a necessary thing that we need for fertility, and it provides really just the fluid that the sperm are able to move through. But for all the diseases that it causes, it's not a very glamorous job that it has. It has nerves that surround the outside of the prostate that control erections. So those are on the very, very outside of the prostate. And we'll talk about the prostate a lot as an orange later, kind of an orange with the rind and the fruit. So those nerves on the outside of the rind. And it does not produce testosterone. That's an important note because a lot of folks, when you think about things that may happen or treatments that may occur with your prostate, it does not actually affect testosterone. Testosterone is produced in the testicles. So the two things I want to talk to you about today are prostate cancer and then enlarged prostate, which is called BPH, or benign prostatic hyperplasia. That's a non-cancerous enlargement. And a lot of times these talks are separated. So you'll have a conversation about prostate cancer, you'll have a conversation about BPH, you'll have a conversation about PSA. But when you see a urologist, we're thinking about all three things at the same time because there's just an incredible amount of overlap that occurs there. So I've tried to hopefully, and I hope that it doesn't confuse anybody, talk about both things at the same time for the entire conversation. So let's think about the anatomy, okay? Yes, it's this gland that sits underneath your bladder and you void through it, all right? But it actually has two parts to it, all right? So there's, if you think of the prostate, there's the rind, the outside of it, the peripheral zone, and then there's the transition zone, which is the center, the fruit, okay? The center of it. And BPH, which is the disease where you have a prostate that gets bigger. Guys say, I have a big prostate, my stream is slow. That's a disease of the fruit. That's the central part. It makes sense because if you see where the urinary channel is, it's just that little crevice in the center. If that fruit gets bigger, it's going to squeeze the channel. Prostate cancer actually predominantly, over 70% of the time, actually occurs in the rind. So most people, when they have urinary trouble, it's not prostate cancer, right? It's usually BPH, but both things need to be checked, and that's how a urologist looks at both things at the same time, and you may be getting different conversations about both things. So again, we're going to be talking about this sort of fruit and rind analogy throughout the whole talk, all right? So everybody's prostate grows. We learned this from the Olmsted County study. Basically, they took a bunch of people outside the Mayo Clinic, and they followed them for 30 years. So everybody's prostate grows, and that's normal. It just depends on if it grows and causes a problem or if it grows and never causes a problem. And with that growth, you have two separate simultaneous events that occur. You have the growth of the fruit of the orange, the transition zone, where you can see by age 80, 90% of men have BPH. There's some compression of that little tube there that's actually causing you to have a slower stream or a sense of incomplete emptying. But at the same time, by age 70, you have a good fair number of people that have a little bit of prostate cancer. And when I say a little bit of prostate cancer, that's important for people to know that most prostate cancers don't kill people. Most prostate cancers men take with them. They don't get taken as a result of it, if you follow what I'm saying. So it is a very common condition and it needs to be evaluated, but both things are rising at the same time as a man gets older. So let's talk about the fruit, benign prostatic hyperplasia, that central part, right? It's a non-cancerous enlargement. It gets bigger. It pushes on the ability to exit, to have the urine flow out, and so you have trouble passing your water. As the fruit enlarges, the bladder may change over time. So you have things at first that you may notice that are symptoms, but those things may be secondary to things that have been occurring for 10 years, meaning your first symptom may be that you have frequency and urgency. Well, the fact that you have frequency and urgency, if it's from BPH, is because your bladder has been trying to push through an obstruction for the last 15 years, and now it's become overactive. Right? So that's the first time you even notice it, but it's been happening for a long time. What are the symptoms of BPH? So you have the slow stream, incomplete emptying with straining, urinary frequency and urgency, which is really just a response of the bladder to the obstruction, standing up for a long time, and excessive nighttime urination. And then you see that list of things there in terms of excessive nighttime. There's a lot of other reasons people get up at night, okay? So if you're, an average man is getting up 3 times at night, all right, I will say maybe one of those times is from BPH, one of those times is from fluid consumption in the evening, particularly alcohol, and one of those times may be from a problem with your heart or your lungs or excessive fluid in your lower extremities. And so that has to do with more production of urine that your kidneys are making rather than any kind of dynamic process between the bladder and the prostate. There's no blockage maybe. Some men just get up at night and some people get up at night because they drink more fluid. So what happens to the bladder over time? So let's say, we just leave this prostate and let it grow and continue to cause obstruction. Well, most of the time actually, most people do okay. And what do I mean by that? They'll live their life and they'll do the one thing that they have to do, which is get the pee out. Right? They just get the pee out, and that happens without stones, infections, or bleeding. They may not like the way that happens. Their quality of life may be affected, but most people will not have severe issues with this. But some people, if you leave it in place for long enough, it'll cause one of two things to occur. The bladder will either become thick, and is this muscle that's been exercising, trying to push the urine through. It's going to become thick and overactive. Frequency, urgency, and leakage, urge incontinence, right? So you actually leak before you can get to the bathroom in time because your bladder's squeezing without your permission. Or the other way around. You have bladder failure, just balloons out and is unable to squeeze, and those men may end up with a catheter in the emergency room. And then you're coming to see us, and we're talking about what procedures we can do to get rid of that catheter so that you can urinate better. So what are the severe things that can occur from BPH? You can have an inability to urinate, and if that's silent and you don't realize that that's happening, and maybe every time that you urinate, you may be actually leaving half a liter or a liter behind in your bladder, you're not feeling that sensation that you're full, that may actually back up into your kidneys and cause your kidneys to fail. And some of that may be irreversible, so that even if we catch it and fix it, whatever injury has occurred to the kidneys from that time has already occurred, and you may not be able to get that maximum function back. Some men with extremely large prostates, which is sort of my area of expertise, is the jumbo version of this problem. It can have recurrent bleeding, recurrent infections in the bladder or of the kidney or the entire urinary tract as a result of that blockage, and bladder stones. Now, interestingly, most people, you think bladder stones, kidney stones, stones are stones. Well, kidney stones form for a completely different reason. Bladder stones form because of prostate problems, because of obstruction. So if you have a bladder stone, it needs to be removed, but the root cause is the prostate. So if you just get the stone out, it's kind of like a Band-Aid. You get the stone out and fix the prostate, you've addressed the root cause and fixed the whole issue. So many men who suffer from BPH experience a reduction in quality of life. The things I just put up on that slide earlier, those are the times a urologist says, hey, you really should have this done. You're having a problem. Your kidneys are failing, you're bleeding, you're infected. I mean, these are medical issues, right? These are the times where I may say to you, I think you should have this done because this is going to be better for your overall health. Quality of life, as long as you're getting the urine out of your body and your kidneys aren't swollen and you're not getting infections and blood in the urine, that's a time where the patient needs to tell me, hey, I'm really not happy with the way that the urine comes out of my body when it does, or that it takes a long time, or that I go too frequently, or that I leak. So that's a conversation that needs to occur with your provider to really understand where's that balance point and the risk-benefit ratio of doing nothing at all, doing something minimally invasive, or something a little more invasive but permanent and effective. So how's your urologist going to take a look at you? History is really important. Now, this is not the only disease process that causes blockages and symptoms. In fact, urology, all the symptoms are the same. It's frequency, urgency, blood in the urine, and that can be 1,000 different things, from infection to cancer to scar tissue in the urethra like stricture disease. So the history is incredibly important. So part of that is going to be that discussion. The examination is important. A urine test to make sure you don't have an infection. Right? And a PSA, which is a blood test that looks at your prostate health. And a bladder scan to make sure that you're emptying your bladder completely. So the examination, it's really important, although uncomfortable. I understand a lot of folks don't like having it done, but it's really important. And you know, these days, if you're going to see a urologist, that might be the only person that does an examination of your prostate. So it really gives us a rough estimate, and as well as an understanding of whether there's any big lumps or bumps. Remember that the peripheral zone, the rind of the orange, that's the typical place where cancer occurs. So we can feel at least the back side of that area through a thin wall in the rectum, and that's why we're doing the exam transrectally with the finger. PSA is a screening test that looks for prostate cancer. It also looks for prostate problems, prostate enlargement, prostate inflammation. So it's a very non-specific test, and I'll talk about that in just a second. So if you're coming in for urinary problems and we're taking a look at your prostate, we're probably going to get a PSA, because we want to make sure that we're doing a thorough evaluation, preparing you for any kind of procedure you might need. When we talk about screening for prostate cancer, we're using a PSA test to see if it's abnormal. And when we have that discussion, it's not just hey, everybody should have a PSA. It's really, we have to make a determination of who's going to benefit from a little tiny elevation of us catching a small prostate cancer that in the next 10 to 20 years is going to harm you. And that's really difficult to do, because no one has a crystal ball. No one knows how long anybody's going to live, but we do know that men in their 50s are going to derive a lot of benefit from screening, versus particularly men in their 80s may not. We may catch something small, but it will never do anything in your lifetime. The problem with that approach is that it's not about the number, it's about life expectancy and overall health. The guy on the left is not the guy on the right, and that man is 82 years old. So I think we look at a man as a whole. What is your family history? How long did your parents live? Do you exercise? Whenever a patient stands up in front of me, I look at how quickly it takes them to stand up from the chair to understand it's a really, really quick test of somebody's kind of overall health, is how quickly you can stand to arise. So this is a long discussion to decide whether you should get a blood test, right? But you may say, well, how can a blood test hurt me? Well, it's not the blood test itself. I mean, the needle might be uncomfortable, but it's what are you going to do with that information after you obtain the results of an elevated PSA? Because then the next step is, are you going to do a biopsy? Well, biopsies have risks of infections and bleeding, and even sepsis, and rarely blood clots and death. There's all kinds of things can occur. It's the medical spiral. You do one thing, then you do another, then you do another. It creates a lot of anxiety. So should we get the blood test is the first question, and I think it's really just about informed decision making. You talk about it with your provider. Is this blood test something that's going to help me in my lifetime? And if the answer is yes, then we get it. If the answer is no, we're not putting our head in the sand and saying we don't care about the prostate. We still continue to do the yearly exam. It's not that we don't care about prostate cancer, we just change the lens through which we look at it through. So we're not looking for tiny, early, detected, localized prostate cancer. We're looking for bigger things that might hurt you if your life expectancy is less than 10 years. I can talk about just this question for probably an hour, so I'm going to move on. But that's why PSA is so complicated, is because it's not a good test. It doesn't look just for cancer. It looks for a lot of different things, and it's a discussion that you have to have with your doctor about getting it. So let's just say that PSA is normal, the urine's normal. You're here for some urinary symptoms, and you want to address those symptoms. And I will just say this once again: the PSA itself is not bad for you. Okay, so cholesterol being high is bad for you. Diabetes and having sugars that are high is bad for you, because those things will lead to heart attacks. PSA is not a thing that, if it's high, inherently hurts you. It is just a signal, like a marker to say look for this or look for that, okay? So going back, your PSA is normal, urine's clear, you're just here for discussion of your symptoms, you don't like the way that you're passing your water. So what can we do? Well, we can just not do anything. What we check for in the office is make sure your bladder is empty, making sure you're not having infections, make sure that you don't have cancer. And if all those things check out, and you say, is this okay? Can I just keep going the way I am? Yeah, you can. There might be some risk that your bladder function might worsen over the next 10 to 20 years, but I think certainly in the next 6 months we can continue to observe it. I don't think there's any harm there. We can trial a medication. And then we can really say, okay, let's figure this out. Let's take a look in the bladder with a camera, let's ultrasound your prostate, and let's see what the actual anatomy is to figure out how we can help you. So in terms of medical therapy, there's going to be 3 different classes. There's alpha blockers, 5-ARIs, and things like Cialis. So your alpha blockers just kind of relax the prostate. Right? 5-alpha reductase inhibitors, they actually shrink the whole prostate. That's the finasteride, dutasteride group of medications. They can have some side effects like ED and libido, erectile dysfunction, libido. Cialis, it kind of just relaxes the bladder, but it doesn't actually improve your stream. We're not really sure how it works, but we do know as a side effect, guys get erections, so it's selling like hotcakes out there. So this is the only medical graph I'm going to show you, and it's an important graph to see, because if you get on the medicine train, the real benefit to medications, and you incur a little bit of side effects, and usually there's sexual side effects, but the medical therapy is from combined therapy. So I don't know if you can see that red line in the bottom. The red line in the bottom is when you take both medicines, both something like Flomax and finasteride together, and you take it forever, because one shrinks the gland and keeps it from growing quickly, and the other one relaxes the prostate. Those people, you see, had the lowest event rate, meaning getting an infection, getting a bladder stone, not being able to pee, ending up with a catheter, or transitioning to surgery, right, as opposed to all the other groups, with the top one being nothing, and then the green and the blue bars being, just your Flomax or just your finasteride or dutasteride. So if the medicine from a long-term perspective is a get on it, stay on it, and then derive all the benefit from it, but accept some of the side effects for that. So size and shape matters. This is why we need to evaluate everybody's urinary tract separately. First of all, we need to make sure that we're correct and that BPH is the actual problem. It could be like something like a stricture or even sometimes a bladder cancer, which is why we check the urine to make sure there's no blood there. So we look with a cystoscope in the office and an ultrasound in the office typically, or if there's any other imaging around that you've had in the last year, we can just use that as well, just to check the size of the prostate if that's available. And we really want to find that there was the right procedure for the right problem, for the right prostate, for the right man. So it's actually, there's so many things you can do, right? But medicine shouldn't be a lollipop shop, right? You're not coming in and getting strawberry or vanilla or blueberry, right? You should have guidance as to what's right for you. And really with prostate problems, there's really that perfect treatment now that some of the newer therapies have come out, that perfect treatment for kind of fitting all of the therapies exactly to where they need to be for the right person. So the right problem, medical indications equals definitive therapy. What does that mean? If you come into the office and both your kidneys are swollen and you're in kidney failure and you're forming stones and you've got a 150-gram prostate, that's really big, okay? You should not have a small procedure or be on medications. You should have an effective procedure that should fix the problem, that you don't have to deal with that problem again, but that procedures might have a little bit more side effects for you in the long term. But nevertheless, you should do the right thing for the right problem, right? The right prostate, size and shape, right? So you can obviously see the walnut there on the left is a completely different thing than the melon on the right. So some of the procedures that work best for the walnut and the orange, they're ineffective. We may as well be doing placebo on you if we're doing them on glands that large. So we need to make sure that when your doctor tells you, hey, your prostate's just too big for this procedure, it's not because we don't want to give you that procedure, it's because that's the right thing for you. It's not going to be effective. You're going to go through a whole process and probably derive only side effects rather than any benefits. And then the right man. The importance of ejaculation, it really kind of all boils down to that one act. And I'll kind of break down, that part of male sexuality a little bit later in terms of, you hear this thing, well, this medicine has sexual side effects, or this surgery has sexual side effects. Well, which parts are the ones that matter, and which parts are the ones that are going to get affected, and which parts do you actually care about that are going to influence your decision making and which procedure you're going to have. And so that conversation is really important, and really when we talk about the therapies, it's really all about the emission of fluid from the tip of the penis. It's the ejaculation that's really the difference there for a lot of the different therapies. So when I say no free lunch, I mean more effectiveness typically comes with more invasiveness. So this is, I'm sorry, I said I'm only going to give you one medical slide. This is my only other sort of doctor slide that I put up there. But if you look at the medical therapies, right, that's the medicines like dutasteride, finasteride, and tamsulosin. You've got that Qmax number. It shows that you get 2.5 milliliters of flow rate increase, meaning that the pee comes out faster by 2.5 milliliters per second. That's a velocity, right? If you look at some of the MIST therapies, that's sort of the minimally invasive surgical treatments, like Resume and Urolift, it's about 3.5 milliliters per second, all right? So it's faster, but if you look at those side effects in terms of incontinence and ejaculatory dysfunction, that's the loss of fluid from the tip of the penis, or erectile dysfunction as well, it's really low. So some of those minimally invasive treatments have almost no sexual side effects at all, and are better than medicine by a little bit, okay? And if you compare the last one, and I'm using HOLEP or laser enucleation as an example, which is what I'm calling a definitive therapy, look at the flow rate there. That's 14 milliliters per second. Compare that to 3.5, all right? That's a 400% increase. That box should actually be on the other side of the wall over there to give you a fair and accurate representation of the difference between minimally invasive treatments and medications for quality of life versus my kidneys are failing, I need a real operation to solve the problem. And I think that's important for people to realize when we have these discussions. Of course, it comes with a price, and that's nearly 80% ejaculatory dysfunction. So there's no free lunch, but there's a pretty good price, I would say. It all kind of makes sense, and there's value based to that. So let's talk about prostatic urethral lift, which is Urolift. And this is a great new advancement in technology. It's extremely minimally invasive, basically these little tines that get put in and just open up the channel a little bit, all right? So it's better efficacy than medication, and it has less side effects than medication. That's great. Who is this meant for? This is meant for the millions of men in the world who take a little Flomax and don't want to take it anymore. It works great, and then you don't get any of the ejaculatory dysfunction. It is typically no catheter after the procedure too. But it's less effective than surgery. How much less effective? 400% less effective. So it's just important that we talk about these procedures in light of where they're good, but not in light of the other procedures that are really meant to solve real problems. 13% at 5 years need surgery, and a lot of those patients restart medication, so there's a lot of retreatment in the future that comes with this. You have to understand that you're preserving some sexual function, but you might come back and you might need another operation, and that's fine. We can do another procedure for you 5, 10 years down the road. And it's only meant for prostates less than 80 grams and no median low, which is just a shape thing. So another minimally invasive surgical treatment is Resume. Another great advancement, similar data. It's better than medication. It has less side effects than medications typically. And it preserves ejaculation 98% of the time, which I'm just going to say 98% of the time, 100% of the time, that's pretty close. So for preserving ejaculation, I think that's a great option. And I think anyone who's worried about having some sort of implant or something like that, I think it's nice because it's sort of a leave no trace procedure, as one of the big proponents, Dr. McVeary would call it. So it is still less effective than surgery. Again, how much less? 400% less, all right? So potential for longer catheter time for a procedure, you are heating up that area, there's some steam injury that occurs, you might need a catheter for a couple days, rarely maybe even a couple weeks. That could happen, people need to know about that. 4% though is much better than 13, need surgery at 5 years, but a lot of those patients again restart medication. So you're saving a lot of that sexual dysfunction, you're saving a lot of those things. You have to ask yourself, is this important to save for you and worth the potential for restarting another medicine in the future? This one's only meant for prostates less than 80 grams as well, but can treat a median lobe, which is that shape thing again that we talked about. Next would be resective surgery. So this is sort of the tried and true. Urologists have been doing this for over 50 years. Before resection, there was even something called the punch, where they actually punch the tissue out. And so TURP is transurethral resection of the prostate. Now, the green light laser therapy is probably one of the best examples of this, where you basically just destroying the tissue with a laser. It's a rapid destruction. It's a very low risk of bleeding, and it works really well to open up that channel. And going back to the fruit analogy, that orange, you can see that if you're looking at the fruit, you're basically just from the inside of that channel shaving out a much larger channel, right? But you can see how much you're able to shave or how much you're able to accomplish depends on the size of the fruit, right? So if you're trying to shave a melon, you're never going to get to that core. You're never going to get to that rind. You're going to have a lot of stuff left over. So what are the advantages? Significantly improved flow rate and more durable, right? So the less people come back for a second procedure. We've been doing this for almost 50 years. And then TURP will actually obtain tissue, so we can analyze it under the microscope and look for prostate cancer cells. The disadvantage, a little bit more invasive. There is a slightly higher risk. There will be a loss of ejaculation a fair amount of the time with this procedure. Very low risk of incontinence, about 1%. And then there is some scar tissue formation that can happen in the urethra tube because these instruments are larger. They're more invasive. So we may leave a scar once things heal up, and then that will cause a blockage, and then you'll need a second procedure to fix that. And that risk is about 2 to 4%. So there's no free lunch, but it's well priced. So how does laser resection work? Well, basically we go in, and if you, again, this is another example, the white is sort of the fruit, and the pink is the rind. So you're just destroying that fruit and then creating a much larger channel, which works really effectively. And if you have really experienced people like Dr. Langston or Dr. Yor performing these procedures for you, then you have an opening that's really excellent if you're a well-selected patient with the right size prostate. So let's talk about anatomic endoscopic enucleation. So that's a mouthful, but basically you're just taking out the whole fruit. That's it. So 100 years ago, urologists would make a big cut in your belly and then just do it with their finger. And then we figured out how to do it with a robot, and then we figured out how to do it with a laser and a scope without making any incisions. So now it's an endoscopic procedure where we're removing the whole fruit. So what are the advantages? It's outpatient. Your catheter stays in for less than 24 hours. It is the best improvement in flow rate and emptying. It is the best chance for becoming catheter-free if you've had a catheter. It's the best reoperation rate, meaning that only 1% of men at 18 years of follow-up will actually need a second procedure for their BPH. It's the most tissue removed, so of any given gland, you're removing anywhere between 50 to 95% of the tissue. It just depends, again, if it's a clementine, you're removing all the fruit. If it's a watermelon, you're removing all the fruit. So either way, you're removing all of it. And you're getting it all for analysis under the microscope to make sure there's no cancer. And because of that, you have the largest decline in PSA. But that's not a reason to do it. PSA isn't bad for you. It's just a bonus that you get. Your PSA typically goes down to below 2, most often below 1. Now, what are the disadvantages, right? No free lunch. So high chance of temporary incontinence. So right after the procedure, there's about a 3-month period, 6-month period, potentially even, that you might leak a little bit. You might even leak a lot. But the risk of it being permanent is 1%. The risk of being permanent is 1%. So it will get better. It will probably happen, but it will get better. And almost everybody gets ejaculatory dysfunction. So you lose the ability to have fluid coming out of the tip of the penis after orgasm. And then the same scar tissue risks because you're using a bigger scope with a laser. It's just a little more invasive than some of the minimally invasive surgical treatments. So what's the difference between enucleation and resection again? So yes, it's a laser. Yes, it's a scope. Yes, it's outpatient. Yes, you have a catheter. Everything, you can't tell the difference. But internally what happens is that we remove the whole fruit or remove part of the fruit. So which treatments affect which part of sexuality? All right, so this is, like I said earlier, it all comes down to kind of ejaculation. If you look at it, really, medicines like finasteride, which may be a really great medication for somebody who's on multiple blood thinners and has some medical problems and is really trying to avoid surgery. But if you're looking at the sexual impact, it decreases libido, it may have impact on erections, and it changes ejaculation. Medicines like tamsulosin may also change your ejaculation. And then enucleation, TURP, and green light, photovaporization, may also change your ejaculation. So it's really the fluid coming out of the tip of the penis at the end of orgasm that gets affected by some of the medicines and then and all of the surgical treatments that created this space for the missed therapies, the minimally invasive surgical treatments like Rezum and Urolift, because they're not on this list at all. So really they're an improvement on medicines with less side effects than medicines, and it's a great option. So let's go back to that PSA test. right? So that's kind of the fruit talk. Now we're going to go to the rind talk, right? So the outside part, the part that gets cancer. So what if it was abnormal? Well, first of all, what does that mean? Why are the ranges so huge here? In your 40s, less than 2.5 is normal, but if you're in your 70s, less than 6.5, is it because we care less about 70-year-olds than we do about 40-year-olds? No, it's because the fruit and the rind grow together over time. So you get a lot of confounding information from the growth of the fruit. And so most men in their 70s will have a larger prostate. So what's normal for them is going to be different. And that's why you have those numbers. First step to do when you have an elevated PSA is take a deep breath, because it's okay. We have to treat anything that's not, that may be a confounding variable. So you have an infection, you had a catheter last week, you rode your bike for 13 hours, and then you decided to go get your PSA checked. So we just want to repeat it first to make sure that it's a true test. A lot of times it comes back as normal, and that's it. Was that little moment and sliver of time where your PSA was abnormal, bad for you? No, because PSA isn't bad for you. PSA is just a marker, okay? It's just a marker. PSA is just a marker. It's just a flag that goes up and says, urologist, please check to make sure that there's no prostate cancer if that's clinically indicated, all right? And if that's already been done, it's okay. We may need to continue to watch you over time, but it's okay. So once we've confirmed, if the exam is abnormal, sometimes we may jump straight into a biopsy. So if your prostate shows a nodule and your PSA is elevated and you've never been checked for cancer before, there's a high chance that that's what it could be. And so we may just jump straight to a biopsy. But if your PSA is high and you've never had a biopsy and your exam is normal, there's a lot of different options that we can do. One of them being just repeat every 3 to 6 months for a little while to get a sense of a trend. Why? Because one value is helpful, but seeing multiple values over the course of a year is really helpful, or 2 years, or 5 years. It's a very, very helpful thing to be able to understand what the trajectory is. Because some people go 3, 6, 3, 6, 3, 6, 3, 6, and they just live there for 10 years. And some people go 2, 6, 12, 20, and that's concerning. So those are two different individuals that have that trajectory of PSA. So getting a little tincture of time to help us understand what's happening is very helpful. We can calculate the density. So if we have an image of your prostate and it turns out that it's 200 cubic centimeters, normal being 30, if it's 200 cubic centimeters, then we may understand that, hey, that's why your PSA is a little bit more elevated. You've got a really large gland, and so that's the reason that it's producing more PSA. We have a prostate health index and 4K score, which are blood tests that are a little bit more accurate than PSA in general that we can double check with. You have something called Select MDX, which is a urinary genetic basically test to look for some abnormal genes in the urine that you may be able to perform as a kind of a gateway to decide about biopsy. And then you have Exosome DX, which is a newer test that's been very well received, and some of the data is very promising on this. As well, looking at some genetic material in the actual urine. And then you have MRI, which is very helpful. So how does exosome work? Why am I speaking on this? Because this is probably a trend that will push forward. There's other companies in this field as well. It's the fact that if you take this test and really say how many men with a totally normal test have a high-risk cancer or a cancer that's actually going to hurt them with a high chance, and the test comes back normal, that's 98% that's correct. So it's called the negative predictive value. The negative predictive value of this test is 98% for Gleason 4+3 cancer. So that's pretty good. So that could be helpful in making that decision when you're on the borderline about what to do. MRI of the prostate is great. It gives you a picture. It's not a biopsy, but it gives you a picture. So if there's a spot there, we can potentially target it. It has to be this very specific type of MRI. Very often you'll be sent to a very specific place to get it because it needs to interface with some other technologies that I'm going to mention. But if you come to prostate biopsy, there's targeted and standard. So if we're having to biopsy the prostate, you can do just a sampling, a templated 12-core biopsy that's performed via ultrasound, or if you have an MRI to go off of, then you can actually use that, do the 12 cores, and then hit that spot. The technology is called a fusion biopsy, and we lay the picture of the MRI over the picture of the ultrasound, and those two things together give you a really nice image to be able to access exactly where that spot is. The spot is just a spot. It may not be cancer, but at least it gives us a target that we can hit. So let's say you are diagnosed with prostate cancer. The first thing to do is actually to take a breath. It's the same as the PSA conversation, because prostate cancer is an extremely slow-growing cancer most of the time. When you compare with other malignancies, it's far less aggressive than things like pancreatic or lung. Now, there are some that are pretty aggressive, and that's the key in figuring this out. So we can divide it into group 1, 2, 3, 4, 5. So group 1 is the least aggressive, and in fact, for this, we recommend that we watch it, almost in everybody. Group 1 prostate cancer typically is best treated with no treatment at all. Group 2, it's really one or the other. It depends on age, and we have some other testing that can help us decide what to do. Group 3, 4, 5, you typically benefit from testing. All right, so from treatment. So when you hear the words, I have prostate cancer, obviously it's a shock. But prostate cancer is like 100 different diseases, all with the same word and name to describe it. So you really need to know which one it is, because sometimes, or about 50% of the time, the best treatment for prostate cancer is active surveillance. It's just watching it, because we're going to cause more harm by treating it than good. So you may require staging. Not everybody does. For low-risk cancers with low PSAs, we don't need to do any of these imaging studies, but CT, bone scan, and MRI, these are used to just understand, to make sure that it hasn't spread outside of the prostate. So what's active surveillance? So active surveillance is not, hey, you have prostate cancer, but it's really not that aggressive, so go home and never come back and see us. Active surveillance is active. It means you have to keep coming back and seeing us so we can keep surveying to make sure that the cancer doesn't progress or advance to something that now requires treatment. And so we use PSA, examinations, MRI, repeat biopsies, as well as some genomic profiling. So we can actually take the genes from the cancer itself and see, maybe learn some more information about it to decide about whether you need treatment. So some examples of genetic profiling would be a Decipher prostate biopsy test or an Oncotype DX. So I utilize these for a lot of men with a very low volume, grade group 2, maybe Gleason 3+4, grade group 2, favorable intermediate risk prostate cancer, where you're on the fence, you're not sure, should I do treatment, should I not? I'm 68, I have some diabetes, maybe I'll be helped by this, maybe I won't in my lifetime. This might be a tiebreaker. You might be able to take a look at this and say, hey, this is pretty low risk genetically, let's just watch. Or, hey, this is pretty high risk, maybe we should treat this, because maybe our biopsy wasn't quite catching the whole picture. So that's a very helpful test in the select patient, not a test you need to get on every patient. So what if you have a disease of the fruit and a disease of the rind, right? So what if you're doing active surveillance for your prostate cancer, and then your prostate keeps growing, and now you need a treatment for it? So in my opinion, HOLIP is, or enucleation is ideal for treating BPH in this setting. And the reason for that is because you remove, again, maximal deobstruction, but you really get a maximal tissue analysis. So if you're on active surveillance for prostate cancer, it's nice to be able to remove 80% of that tissue and then take a look at it under the microscope. It is not a treatment for prostate cancer. It is not a reason to do the procedure. But if you have BPH and a lot of urinary symptoms and you happen to be on active surveillance for prostate cancer, it's a great option. Because your PSA after that procedure tends to go down to below 1 or 2, and it makes it that much easier. That might be one less biopsy or MRI that you might need in your active surveillance regimen for the rest of your life potentially. So what if you need treatment for BPH and prostate cancer? Right? So you're not actively surveying the prostate cancer, but you're a man who's been diagnosed with prostate cancer and you have really severe urinary symptoms. Why? Well, one is usually it's due to the fact that you have one disease of the fruit that's overgrown and causing a blockage, and a second disease of the rind, which is the cancer. So what is the only treatment that fixes both? It's a radical prostatectomy. So it's surgery to remove the entire prostate. That's typically done robotically with an overnight stay in the hospital, through 6 little keyhole incisions through your belly, with a catheter for about a week or 2. But there is a long recovery for that, with incontinence potentially, and some sexual dysfunction that could occur. So there's no free lunch with prostate cancer either, unfortunately. But at least knowing that when you look at your BPH treatments and you look at your cancer treatments, the only one that falls in that Venn diagram that really addresses the prostate problem from both components of the rind and the fruit, it's radical prostatectomy. So But not everybody really should get a radical prostatectomy. And maybe if you're a little bit older and have some more medical problems, your risk of incontinence might be really, really high if we do that procedure. So maybe the best thing for you is to get your BPH treated and then undergo a second treatment for your cancer that may be in the form of radiation. So the only thing that's important to know about there is that you should get a treatment first of your BPH first. Always fix the BPH first and then get the treatment, because once you get radiation, kind of locked in. Basically, if you've had radiation and you have urinary trouble after that, we have a lot of trouble fixing that. There's not a lot of great treatments. Maybe one of the few treatments that can help is Urolift if the gland is of adequate size. But you want to do something effective and durable, and you want to do it while the tissue is still able to heal well, and then you can do radiation later. So you really address these different diseases differently, and you address them as two separate diseases, but sometimes things overlap. So what if I need more treatment? I've had a prostatectomy, and I can't decide, do I need radiation now? A lot of cancers are treated with surgery and radiation and chemotherapy, and if you've had your prostate removed for prostate cancer, the question is, do I need more? Do I need radiation? And so we use the margins on the specimen, the actual aggressiveness of the cancer underneath the microscope to make that decision. But sometimes we're still on the fence, because a lot of patients, even with some of the more aggressive features, they may never have a problem. And to give radiation to that person and have them endure the side effects of it is not something we take lightly. So the Decipher prostate RP score is a similar thing that we looked at earlier, that you're looking at the actual prostatectomy specimen and you're saying, what is the genetics of this cancer? Is this something that's going to come back? And if it's a really high-risk score and we're on the fence, that could be really helpful in deciding to make sure that we do give that radiation early. We don't wait for the PSA to come back. We just give the radiation. What if you've gone through all of this, and most men are cured? Most men don't need treatment. The ones that do are cured. What if you're one of the few men that went through all this and the disease comes back? Okay, so here in Hampton Roads, the best test for looking at where is the disease after primary treatment, that's radiation or surgery, it's called the Axumin scan, and it's a PET scan, but PET scans have traditionally never worked in the past for prostate cancer because it handles its energy source a little bit differently than other cancers, but this is a specific prostate cancer PET scan, and so we're able to identify the sites of disease after primary treatment. There are other things out there like PSMA scans. There's a C11 PET choline scan, which I wrote a bunch of papers out when I was at Mayo, but here we have this, and it works well, and it has a great utility after that in that setting. What are you going to do with this information? Well, you can find the lesions and you can hit them with radiation. You can decide about hormones, second-line hormones, immunotherapy, and this one slide that somebody who's a prostate cancer specialist can stand up here and probably talk to you for an hour just on this one slide and the differences. But the idea is we then use that information from the scan. It's good to know where's the disease so I can decide about treatment. That one's pretty easy for most people to understand. So hopefully I haven't gotten too far over time, but that's it. Did anybody have any questions? So you mean, for the lack of erections and the lack of ejaculation potentially, that would increase the risk of prostate cancer? I don't know of any data that would support that. Dr. Langston, do you know any that ejaculation is good for you?
And there is some that suggest that ejaculation actually helps, more frequent ejaculation helps decrease the risk of prostate cancer. But yeah, it's definitely not something we're going to write a prescription for at this point.
As a whole, probably sex is good for you. Safe sex, whatever it may be. As a whole, it's generally good for you. But yeah, we'll say that. Yes, sir.
What volume of retained urine would be alarming that something's not working?
Yeah, it's a great question. So, in fact, if you line up 10 urologists, you're going to get 20 opinions on that question. So it also depends on if it's a Friday. I'm just kidding. That's a joke. 350 milliliters is the definition of chronic urinary retention. All right. So if you've got more than 350, consistently after you pee, that's highly abnormal, and it mandates treatment by the guidelines, so to speak, right? Now, 349, is that okay? No. So it's a continual spectrum. If you have 0, that's great. If you have 50, probably not a big deal. If you've got 100, it's okay, but you're on my radar. 150 to 200, now I'm really talking to you about maybe something in the future. You get up to 250, 300, I'm saying, hey, this is serious, you're at risk of infections. 350 or higher, we start using the C word, not cancer, catheters. All right, 500 and higher, I'm starting to say you're going to kill your kidneys unless you do something right now.
So it's normal to have some volume of retained urine in the bladder even after.
It's a normal variant, I would say. Really, I mean, I think if you take every 18-year-old male and do the test on them, it's going to show that it's typically 0. But within the within all age ranges, if you're getting under 50 milliliters or under 100 milliliters, that's probably okay. You can ask. You don't have to be a man to ask a question. You can ask a question too. It's such a great question because we really don't know the answer to that, but I can tell you that it must. Because some men, and if you want to run an experiment and you're taking Flomax and you're not having that side effect, double down on your dose for a day and see what happens, because you probably will develop that side effect. We don't know. I think some people say, no, it doesn't bother me at all. It's not a problem. You reach climax. You have that neurological sensation of orgasm that goes through the body, and there's the rhythmic contractions of that muscle that occurs, those pelvic floor muscles. They occur, and there's just nothing that comes out. But in some men, they say that that feeling is really not pleasurable to them. When they lose the ability to have the fluid coming down the urethra tube, the orgasm doesn't feel as good. And so that's a highly variable, and so subjective. It's so hard to explain, why one and what does and why it doesn't. But maybe, and I will just sort of give you a theory here, it's possible that the fluid itself going down the tube sends a feedback to the brain and the spinal cord to say it's happening, and then that pushes it to happen more, and then that sends a feedback to keep happening. And so whatever orgasm that people are used to may be really different. It feels like the whole thing just shuts down if it's what we call a dry orgasm. But it's very, very individual. I mean, this is not an area of, I would say, significant study, but it's definitely something that men care about. It's important to have that conversation, and it's very important in the light of, like, if you're going to do a whole lip, you're going to have that side effect, whereas if you do a Urolift, you won't. But why are we doing it? What's the size of your prostate? How many bladders, what are the issues that we're doing it for is important. All right, well, thank you so much.
All right, that was incredible. I think we all really, truly learned a lot there. So we're rounding out now. We've got about 45 minutes or so left, and that's going to be a great sort of overview and discussion on sexual function and what we can do about it, right, from Dr. Ramon Virasoro. So he's one of our senior reconstructive surgeons I don't want to make it sound like you're old. Senior guy with a lot of experience in this area, expertise that he is going to share with us. So he's one of our lead physicians at our Reconstructive Pelvic Health Center, the Divine Jordan Center. So we're grateful to have him. Dr. Virasoro.
Thank you so much, Dr. Langston. Thank you, Dr. Sobel. That was a great talk. I always learn from you, even little bits, despite I'm an old urologist practicing for more than 20 years. And thank you for all of you for attending this today and staying until the end. So let's talk about sex. Dr. Sobel said that sex is good for everybody, and I would agree with him that I would prescribe sex to everybody because that's part of our health. So erectile dysfunction is something that affects many, many men around the world. And we're going to talk about what the definition of erectile dysfunction is, what can we do for men with erectile dysfunction. So the definition is very broad. Erectile dysfunction is the inability to achieve an erection that is satisfactory for the patient, for the person. So any inability to achieve or maintain an erection is called erectile dysfunction. So it doesn't have to be any specific definition but that. And it's very prevalent, like we said. I'm one of 5 boys. I have 4 siblings, so you can see that either me or one of my siblings can have erectile dysfunction in their lives, especially if you are over 40 years old. To understand what erections, what erectile dysfunction is, we need to know what normal erections are. And the penis is a very, very unique organ. I love the penis. I deal with the penis all the time. It's a very interesting organ. You have to love the penis. The penis is the only organ that doesn't have a continuous arterial blood supply. So if you think about the penis, and we'll see more anatomic pictures, it's made of 3 cylinders. The 2 top cylinders are the erectile bodies. We call them the corpora cavernosa. At the bottom is the corpus spongiosum that has the urethra inside. So the 2 corpora cavernosa have 2 arteries that feed them from their base. Those are cavernosal arteries. And these arteries are in a constant tone of adrenaline. So there is not blood flow all the time. Every other organ in your body has a continuous blood flow, but not this, because if not, we will walk with an erection all the time. That would be nice, but not socially acceptable, right? So we don't have a continuous arterial blood supply to the penis. Those arteries, they open up in 2 different situations. When we have some sort of sexual stimulation, whether it's visual, tactile, or anything that arouses us, or at night when we go into the deep phases of sleeping, the REM, so phases of sleeping. And that is why a reason why the body has at least sometimes during the day to get blood supply, because with blood comes oxygen and then nutrients, and that keeps the tissues alive. So what happens during erection? The penis is stimulated. Let's say that in the situations where we get aroused, the penis, those arteries get opened up by substances that relaxes the arteries, and then the blood flows into the penis. And now the blood is going into the penis with arterial pressure. And that distends the cavities, the corpora cavernosa. That distension of the corpora cavernosa compresses the veins that usually drains the blood out. So now the blood is not only entering, but it cannot escape. And that's how we maintain erections. So you can see it's an intricate mechanism, and it can be affected by many things. The way we lose erections is when we ejaculate, like Dr. Sobo was saying. Some chemicals are delivered as well. They're secreted, including adrenaline. And adrenaline helps to contract those muscles to project the ejaculation. But the adrenaline is a vasoconstrictor, so now the arteries are closed again. The veins can drain the blood out of the penis, and we lose the erection after ejaculating. Dr. Sobo was mentioning that for some men, the fact that we don't have projectile ejaculation, let's say for Flomax or a minimal invasive surgery for prostate, is not perceived as a problem. And in fact, some men can dissociate the ejaculation from the orgasm by not having any problems, because we can do that. But that's a different talk again. So what causes erectile dysfunction? You see that the majority of the cause of erectile dysfunction is vascular. Hypertension, cardiovascular disease, peripheral vascular disease, but then diabetes, and these 2 are most of the time associated. So you see why this problem is very prevalent around the world, because diabetes and cardiovascular diseases are very prevalent around the world. And then we have medications. The medications that we use to treat hypertension can affect erections. And then the other one would be, in frequency, would be surgeries, and radical prostatectomy fits in that spot. So very prevalent problem. It can affect quality of life, but affecting quality of life is not the only thing. It can also affect the man's health in many areas, to a point that we in medicine are trying to fight medical insurance companies in that erectile dysfunction should be covered by all insurance companies, because it's not just a quality of life. Not that we are just having sex for fun. we said at the beginning or at the end of Dr. Sobel's talk, sex is good for everybody. And it's been proven that having a healthy sexual life not only is fun, but it also prolongs lives. So that's why it's important for us at Urology of Virginia to help you with erectile dysfunction. And these are your options. Anybody can help you with to treat erectile dysfunction, to detect, to start the conversation about erectile dysfunction, and to start the treatment. Your primary care physician, your general urologist, or a specialist in sexual function, like Dr. Langston, for example. So in general, we have 5 options that are approved and scientifically approved and evidence-based treatments that we can offer to patients. We're going to talk some non-traditional treatments, but we're going to focus on these 5 options, and we're going to go one by one. So oral medications, all of you know the Viagra, the Cialis, Levitra, and I see people in the audience that are more than 40 years old, so most likely you've tried them. And I always tell this the same story. When I started urology after my residency, it's in the late 90s, and Viagra had been around for a couple of years, and I was dating my actual wife, and I say, I'm prescribing so much Viagra that I want to try it. And I say, you don't need it. Why would you want to try it? I don't know, I want to try the medication because I'm curious about it. So I'm in my 30s, and one day, without telling her, I tried Viagra. Guess what? She asked me, did you try Viagra today? So yes, Viagra, it works on anybody, okay? It enhances the erections on anybody. So Viagra, Cialis, Levitra, these medications, they will not produce an erection per se, but they will enhance your erections. And they have side effects like any other medications. They have to be taken properly. Viagra is a short-acting medication, so if you don't take it on an empty stomach, well, probably don't work, because by the time that it gets absorbed with the food, you wasted that window of opportunity where Viagra is more effective, so we tell patients how to properly take it. But then on the other hand, you have Cialis, which is a long-acting medication that it doesn't matter when you take it, so it helps with that not to have to plan when you have sex, because you never know when you are in the mood or your partner is going to be in the mood to have sex. They have side effects, like we said. The most common ones are headaches, flashes in the face. They act as vasodilators, and for the same reason, they are contraindicated if you are taking medications that are directed to dilate your coronary arteries. So if you're taking nitrous or nitroglycerin, there is a contraindication because they can be dangerous. They can drop your blood pressure so severely that you may have a sudden death. So we don't like that. So if you're taking nitrous or nitroglycerin, you have to tell your urology, primary care physician, or sexual specialist that you can't take this medication. The vacuum erection device. This is a device that could be very good in motivated patients. Basically, it's an acrylic cylinder. You put the penis inside this cylinder, and then there is a pump, a vacuum on the other end. That pulls blood into the penis. That blood comes from the veins. It's not opening those arteries, so it's different than having a normal erection, but it's better than nothing. And for those patients that are motivated, sometimes this is an addition of a not so good erection, so they may use it alone or in combination with other treatments like oral medication, for example. It also can be used, and we will see this when we talk about Peyronie's disease in the next talk, for penile rehabilitation or penile physical therapy. So for the motivated patient, it's good. Not many adhere to this treatment. It could be cumbersome. Sometimes it's not convenient, but it's cheap. Is in the range of $100 and $200, and once you buy it, it's yours for life, and they usually last forever. They have some side effects like bruisings if you don't use it appropriately. At Urology of Virginia, when we deliver this type of devices, we teach the patient how to use them. We want them to buy a medically approved pump, but you can buy this pump anywhere, like sex stores, or you can buy it online. Even Amazon can deliver this to your house. The urethral suppository. This is basically a vasodilator that you insert in the urethra. And by inserting this in the urethra, of course, it doesn't go into the corpora cavernosa, like we said, or the erectile bodies. But if you crush this pellet inside the urethra and you need to massage the head of the penis, the glands, then it will be absorbed through the corpus spongiosum, then into the corpora cavernosa. So I see some faces there in the audience that it must not be fun. In my experience, I don't prescribe this anymore. I participated in the clinical studies while I was here many years ago during my training, and it's not that effective. It hurts, and it's expensive. So it's not my favorite, but in case you read about this, it's available. I see 1 or 2 patients a year that they are doing it and they like it, but not the majority. Injections. This is probably the most effective and the most predictable way to restore erections in patients that have moderate to severe erectile dysfunction. They don't respond to medications at the beginning or anymore. Let's say that you try Viagra or Cialis for a while, it doesn't work anymore. You try a combination of Viagra and Cialis, it doesn't work anymore. You have diabetes, hypertension, or you had radical prostatectomy and were not able to preserve the nerves, and now you have erectile dysfunction. You want to restore your erections with some predictability, reliability. This is the way. And injecting a vasodilator into the target organ, the corpora cavernosa, is the most effective way to achieve erections. And when we say erections, just have this in mind. Erection means open up these arteries, the cavernosal arteries, so arterial blood goes into the penis. Because when we talk about penile implants next, we don't say erections, we say penile rigidity, because it's a completely difference between a penile erection and a penile rigidity, right? So this, how does it work? Every time that you want to have sex, you inject the vasodilator into the penis. Again, at Urology of Virginia, we train patients on how to do this. First, we need to find the dose that you need. We start with a standard dose, and we see the response that the patient have at the office in terms of erection, and based on that, we titrate this up and down, and we have 3 different combinations and 3 different medications we can combine in this compound. So it's very safe as long as you do it the way we do it. There are some men's health clinics around the area. They don't care about much training patients or dosing patients, so they just prescribe the medication without teaching much, and they say that send the patients because they don't care. They don't care because they won't treat the complication. The complication will come to us, either through an emergency room or through Urology of Virginia. And the complication, of course, is priapism, which is a prolonged and dangerous and painful erection that lasts more than 2 hours. So be careful, tell your people, anybody that you may know about these men's health clinics. They don't do evidence-based medicine. We can deliver the same care they do under your insurance company. So you inject this about 15 minutes before having sex, and you can expect to have a very good result if the tissue is still responsive. Sometimes the tissue is no longer responsive because either your diabetes, hypertension, cardiovascular disease progresses, or the nerves are not viable. In that case, then we have other options. The penile implants. So basically, it's a prosthesis, and these prostheses get implanted, surgically implanted into your body, into the penis. These prostheses are made of special cylinders that use the space on the corpora cavernosa. And these cylinders can be unique in that they are bendable. So when you want to have sex, you just straighten the penis and they will sustain the pressure of penetration. Or they can be balloons that are inflated by a pump. And the pump is located in the scrotum, and the reservoir can be located either at the base of the cylinders, these balloons, or it can be located somewhere else depending on the model of penile implant that you choose. So there are 2 brands of penile implants and a total of 5 different types that you can choose. And at Urology of Virginia, you have 5 implanters, Josh? 4 implanters right now, right? So Dr. Langston is one of them, myself, and then Kurt McCowan and Jessica DeLong are 2 other reconstructive surgeons that they do penile implants. So the benefits are very obvious. You can rely on that you're gonna have you have a penile rigidity, and look at the slide. I say penile rigidity on the third bullet. because you don't get erection with the penile implant. So that's why I like to save the penile implants as a last resort after talking to the patient and counseling the patient on all the options. And when they choose the penile implant, they know what they can expect. One thing is an erection, and another thing is having a rigidity on the penis. These penile implants are the majority of the insurance companies are covering. Now you have to check your contract with your insurance company, but the manufacturer for these devices, they do have some financial planning for those that are not covered. So there are always risks. The penile implants is a surgical procedure to implant it, so everything that is related to surgery, from infection, malfunctioning of the device. These devices are they usually last about an average of 8 to 10 years, and they're pretty reliable. They've been around almost 50 years now, so they are very reliable. They're very safe. And when they are implanted by a high-volume prosthetic surgeon, then you can be safe in terms of potential complications. I would say that in general, complications around these surgeries are between 1% and 3%. So very low, like Dr. Sobo was saying. No free lunch, but very good price for what we can offer. Non-conventional therapies. There are around, you may have heard commercials in radio, TV about this peak performance and plasma-rich, platelet-rich plasma injections, or even stem cells, right? So the American Urological Association guidelines, which is the most reputable urological association probably around the world, in conjunction with the European Association of Urology, they release a guideline saying that for men with erectile dysfunction, low-intensity extracorporeal shock wave therapy, which is what the peak performance people are offering, or the stem cells or the platelet-rich plasma should not be offered to the general population outside a clinical trial. We do not have yet enough or robust scientific information to offer you this, saying that it's safe. Could it be harmful? I doubt that it will be harmful. It will be harmful for your pocket because they are not cheap. They don't care much about your health or your improvement. They just want your money, so be careful. If you have extra $6,000, go ahead and spend it there. But if not, come to see us, and we most likely will offer you some more evidence-based medicine. So in summary, ED is not just a quality of life issue. It could be a serious medical problem. It can be fixed. Start talking to your primary care physician, to your general urologist, to any practitioners that you see on a regular basis if you have one of these problems, as you have plenty of options, and we are here to help you. Any questions? Don't be shy. I know it's a very personal topic, but I like when questions are. There you go, sir.
I've listened to you, and I understand it's outside the clinical environment. Do you have an opinion on non-pharmaceutical enhancement aids, the capsules and the vitamins and other things to use it, have the same act as the Cialis?
That's a great question. Thanks for asking that, because I know there is a lot of offers about this. So nutraceuticals and nutrients or vitamins or supplements that can enhance your sexual function. And I would say what I heard from one of the most reputable doctors that have researched nutraceutical vitamins, and he said that whatever is healthy for your heart is healthy for your penis, and that applies to anything. So if you feel like your diet is not supplemented, is not giving you all the vitamins and all the nutrients that you need, yeah, a multivitamin is good. Now, just have in mind that everything that is offered outside of the GNC or any multivitamin store is not regulated by the FDA. So whatever you're taking, you don't know what it has. No, nobody controls that. So just be conscious about that. I cannot recommend, because again, they're not regulated, so I don't know what they have. So there's so many that we just don't look at those. Yeah, we recommend not to. If you want effective therapies, those 5 that I just mentioned, if you want to do this naturally, because we respect that when patients don't want to take medication, they want to do things naturally, just like that picture Dr. Sobel showed, the 80-year-old man that was in perfect fit, probably doesn't have any problems with testosterone, any problem with erectile dysfunction, any problem with anything, because his heart, his body is healthy. So diet and the exercise is good. Yeah, for those peptides, again, there is no robust information. Those are either injectables or you had to put in your. Would they harm? I doubt. Are they effective? They have proven to be effective. Do we have enough and long-term data in the scientific world to support this? Not yet. Yeah. Yes, sir. Phew. No, I don't think vasectomy can affect anything in regards of sexual function. Not even the vasectomy should not even contribute too much on the volume of ejaculation. So the effects of vasectomy would be initially in terms of healing and pain and some discomfort in that area, and then fertility. I would say that, but no, it would not increase your risk of BPH. It would not increase your risk of prostate cancer or erectile dysfunction. I think that it may. Has anybody tested this in the scientific world? Probably not in the way we would like to, but I don't see why not to try. I don't see why not to try. It would not harm you for sure. So if you can get benefit, whether it is the placebo effect or true effect from the treatment, yeah, try it. And if you do it along with the other measurements that you just mentioned, like you're going to do a healthy diet and a healthy exercise program, and you're going to do something mindful, so those are the 3 pillars to be healthy, then yes, go ahead and do it. May be part of your mindfulness. All right. Yes, sir. Mm-hmm.
Sometimes it's hard to get the right, to know when the right time. It's not a perfect situation.
Perfect. This is a great question because it allows me to tell you a little bit more of the difference on these oral pills. So, like I said, Viagra is a short-acting medication. When you take it and when it gets fully absorbed in your body, it gives you a window of opportunity where the maximum concentration of this medication is in your system for 4 hours, right? You take it with food, you take it with alcohol, that absorption of the Viagra is going to be delayed. And by the time that the Viagra will not be absorbed as a peak. It will be absorbed as little pulses, because that's how the food in the stomach is delivered to the small intestine to be absorbed as boluses, right? Whereas if you take the pill on an empty stomach, let's say that you just ate and then you wait 3 or 4 hours, depending on how copious your meal was, you take the Viagra on an empty stomach with a glass of water, it will go into the stomach, will be dissolved, and it will pass into the intestine, and then you have the entire pill, and it'll be absorbed as a peak. And that will give you that window of opportunity for 4 hours. So it's not harmful to take it with alcohol, but you're just wasting your money. You're just getting frustrated because you think that it doesn't work. So if that is a problem with you, that it's hard for you to know when your partner is going to be in a good mood or you are going to be in a good mood, then maybe you need to talk to your practitioner about using Cialis, because Cialis will give you back that spontaneity. Cialis is a long-acting medication. The window of opportunity is 17 hours, and it doesn't matter if you take it with food or not. And Cialis, you can take it daily. You can take it on demand before having sex, and you can take it in combination with Viagra. Yes, sir. It may be. It may be. We don't know yet. So could it be the treatment in the future for selective men, but it's definitely not the treatment for everybody that has erectile dysfunction. And the way they report their results is not the scientific way. So when they report 80% success rate, it's questionable. No, we try with Dr. Langston to obtain one of the devices to start a clinical trial, like we all should do. And they are not interested, these companies are not interested in investing in doctor's practices because they can sell their products and their services around the country.
Could I just ask if we could move on to the next portion?
Yep.
Just for the sake of time, and then we'll stick around for all the other questions we get at the end. Just that way folks can go in.
I'll go quickly through this talk. It's basically about Peyronie's disease. So we talk about the anatomy of the penis, but specifically for Peyronie's disease, I want you to focus on the corpora cavernosa. And like we said before, the corpora cavernosa, the erectile bodies, is made of these two spaces, these two cylinders that are filled with blood vessels. Let's call these small blood vessels. They get filled with blood when we have an erection, and that is your cavernosal artery that we were talking before. Now, this erectile tissue is surrounded by this membrane called tunica albuginea. And the tunica albuginea, as you see, has two layers. This inner layer that is circular, and then this outer layer that is longitudinal. So the circular layer, the fibers of collagen, which is what this tunica is made of, go circularly. And in the outer layer, the fibers go longitudinally. They are fused together, but they have some important anatomical considerations. One of which is the inner layer, the outer layer, you can see here, is not present from 4 o'clock to 8 o'clock position. And then the inner layer sends projections from the septum, what divides the two compartments from the base into the 11 o'clock and 1 o'clock position. And the septum, just for you to know, is an incomplete barrier, so there is communication between the two of them. And that explains why some patients, when they do injectable therapy for erectile dysfunction, they only have to inject it on one side. They don't need to inject it in both, because there is communication. But these anatomical characteristics are important when we try to define what causes Peyronie's disease. So what is Peyronie's disease? Peyronie's disease is a scarring disorder. We don't know exactly what causes Peyronie's disease, but we do know it's a scarring disorder in that the collagen fibers are deposited in a disorganized array instead of organized array, like I was telling you, circular and longitudinal. What we know is what happens with Peyronie's disease, and the most devastating things that happens with Peyronie's disease is the shortening of the penis or the deformities on the penis they can cause, because this is a scar, and like any other scars, may contract, may retract, and by tethering the tissues, can create different deformities. Now, the majority of these the scars in the body can be remodeled over time, but because of the location of this scar in between those two layers of the tunica albuginea, it cannot be remodeled because that space is usually a virtual space, and it becomes real with the trauma, and we'll talk about that in a minute. And then the blood products cannot reach and cannot remodel, so that scar continues progressing. It cannot be remodeled over time, and that's why it causes so much devastation. We don't know exactly what causes Peyronie's disease, but the most accepted theory around the world in this field of reconstructive urology is a theory that actually was postulated here at Eastern Virginia Medical School at Urology of Virginia in the late 80s by Dr. Jordan and Dr. Devine. And what they propose is that Peyronie's disease is what causes Peyronie's disease is some genetic predisposition and then minimal trauma during your sexual life. Of course, a specific acute trauma to the penis can also cause Peyronie's disease, but it's not what the majority of the patients suffer. There are some genetic association with Peyronie's disease, and the most common one is the Dupuytren's disease. So if you come to Urology Virginia to be evaluated for this condition, we will examine your hands looking for Dupuytren's disease that is associated in 40% of the men with Peyronie's disease. Again, what causes? The theory says that genetic predisposition, like having Dupuytren's disease, and then minimal trauma. But when do we have trauma to the penis? The most common scenario is when we have intercourse and the penis buckles. And the penis can buckle because it's not fully erect. If the penis is fully erect, it can sustain a lot of pressure. But if the penis is not fully erect, it may buckle. Or if we miss the spot, it may buckle. And that buckling injury, because of the anatomy of the tunical vagina, like I mentioned, can delaminate these two layers of collagen fiber of the tunical vagina. And that's when an inflammatory process triggers in that space, and that inflammatory process continues until it forms a scar, and the scar retracts. So what is first? Most patients with Peyronie's disease have some sort of erectile dysfunction, but also we think erectile dysfunction and the lack of having firm erections may predispose to Peyronie's disease. The problems, again, for Peyronie's disease are the deformities, but the most devastating for the mind of a man is the retraction of the penis, the loss of length, and most patients experience this. 12% of the patient may recover from these lesions, but we think in the reconstructive world it's not just a recovery or a self remission, but instead it's like the disease happens on the other side and straightens the penis. It causes a lot of emotional distress. The man with Peyronie's disease comes to see us devastated. Their mind is devastated. We diagnose this by examining, of course. We like to feel if there is a scar to confirm this. We want patients to bring photographs with their penis in erection. So if you call to Urology Virginia requesting an appointment, and when we ask you about symptoms, you mentioned this, we send you a package that includes some information about how to obtain pictures of your penis in erection. If not, we can deliver those artificial erections that we were talking before, and then do measurements, because it is important to measure the degree of the curvature. It is also important if we examine the patients in the office and we feel that the scar, we call that the plaque, is calcified, then we will obtain an X-ray right there, and then we'll determine if there is a calcification like you see here, because that will determine what type of therapy we can offer you. So what can we do for Peyronie's disease? If it is a minimum curvature or no curvature at all, it's just the scar and it has not affected the erections, then it is reasonable to wait and watch and see what happens. If you want to be proactive during this time, what we can give you is something to protect you against more injuries. That would be to improve your erections. And for that reason, we use Cialis. Cialis, like we said before, is intended for erections, but when you take it daily on a small dose, it may promote continuous blood supply to the penis, oxygenation, and is thought to have some anti-fibrotic effect on the penis. So Cialis may be one of those things that we can offer you on the first visit. We may offer you the vacuum erection device. The vacuum erection device to stretch the penis in two directions, just to promote elasticity or restore some elasticity of the tunical vagina. Historically, we use oral medication for this. Different things have been used, like steroids and anti-fibrotics, even anti-cancer medication was used for this with no benefits. There is no oral medication that is effective for Peyronie's disease. No oral, no creams or anything. It's just the intralesional therapy that we will talk in a minute that has been approved by the FDA in 2013 as the only minimal invasive therapy for Peyronie's disease. Other than that, it's just trying to prevent progression or surgery in selected cases. But I'm going to talk about the shockwave therapy and the traction therapy because those are non-conventional therapies that are available. So like I said, intralesional therapy was approved in December 6, 2013. And I know this date because I was waiting for this medication to be approved. And I have a list of patients waiting for this medication to be approved. And at Urology of Virginia, we started using this very early with Dr. Langston because we trust this medication as we participated in the clinical trials at Urology of Virginia that led to the approval of this medication. So the medication is called Clostridium histolyticum collagenase, and when you hear ase at the end of a medication, collagenase is because it's an enzyme that breaks down the prefix of the name. So collagen enzyme is an enzyme that breaks down collagen, and I mentioned to you that the main component of the scar is collagen fibers. So imagine if you break down the collagen fibers, you can soften the scar, and then by softening, weakening the scar, you can straighten the penis, you can model the penis, and it has been to be very beneficial. This treatment course is delivered in cycles. The cycles comprises 2 or 3 visits, and every 6 weeks you get a cycle, and it's a total of 4 cycles. This is what we do. We first identify the treatment area, either by you bringing photographs or the penis in erection, or we do an artificial erection at the office. What we want to know is the area of the maximum curvature, and at that area is where we are going to inject the drug. The amount that we inject is very minimum because, again, it's an enzyme that digests proteins, in this case collagen, so it's not free of complications. And the idea is to inject this substance right into the scar. Again, to soften the scar so then we can manipulate the scar and straighten the penis. Then either we teach the patient how to do this at the second visit, or they come for an in-office modeling session. What we're trying to do is to manipulate that scar. The scar has been weakened with the 2 injections before, so we usually do Monday, Wednesday, and Fridays, and then we can manipulate the scar, and then the patients continue doing this for the next 6 weeks until they come for the next cycle. These are the exercises that we teach the patients to do at home. This is the maintenance of the modeling sessions that we do at the office. But if that fails, we have surgery as a potential offering. Surgery is more effective, but it's more aggressive. And when you surgically treat a penile curvature, you have to have in mind, if the penis is bent, you have 2 different lengths. Right? If you measure from here to there is one length, whereas if you measure from here to there is another length. So this is longer than this, right? So the penis is already reduced in its size. It's just not completely reduced. So you have 2 options: to shorten the longest or to lengthen the shortest. I have not found yet a man that wants a shorter penis. I'm still looking for it. I'm still looking for him, and I will write an article about him. So why do we offer shortening the penis even more when you already suffer shortening, right? Because the shortening of the penis is less risky for erections. When you lengthen the shorter side, you might compromise a little bit your erectile status. That's why there are different techniques. So to shorten the longest side, what we do is we recreate the tethering on the other side. Let's say that you have a tethering from a scar here. What we do is recreate on the other side the tethering. So by making an incision that is vertical, we close it horizontally, right? And then the penis straightens. That's very easy. It's very successful, over 90% success rate. But of course, it's surgery on the penis, and nobody likes to have surgery on the penis. It's quite traumatic for the mind, and recovery-wise, those patients usually cannot have sex or any strenuous physical activity for about 6 weeks. But it's very effective, and if you already had tried the minimal invasive therapy, or you have severe disease, this is your option. The lengthening procedure requires to cut the scar to release the tethering, not remove the entire lesion, not remove the entire plaque, but cut it at the point of maximum curvature that releases the tension, the penis straighten, but leaves a defect that you patch. And we can use off the shelf grafts, or we can use your own tissue, like your dermis, your skin. But if the patient has erectile dysfunction in conjunction with Peyronie's disease, the prosthesis, the penile implant could be an alternative, as not only will fix the erection problems, but also it will straighten the penis, as there. Sometimes just the placement of the implant will straighten the penis, and if not, we have some surgical maneuvers to break the plaque and straighten the penis at the time that you have surgery. Traction therapy, I mentioned the vacuum erection device before. These pumps can be used, and again, depending on your motivation and how much you buy into this concept, you can get some results in restoring some elasticity and in some cases some length. And the RestorX is a device that was developed by prestigious reconstructive urology at the Mayo Clinic. And it's a device that has proven, as you see on the article here in a prestigious journal in the medical field, has shown to be effective in selective individuals. And it needs to be worn about 2 hours a day. It costs about $400 or $500, and when you buy this device, of course, it comes with instructions. I have a couple of patients that use this device. I talk about this as an option, and then I direct them to the websites where they sell this, which is one of the subsidiaries of the Mayo Clinic. I know, you have any experience, Dr. Langston, with the RestorX?
I really don't, and I was talking about it just yesterday, so
Yeah.
about wanting to further my understanding of how to use it.
Yeah, I think, again, it's one of the options that we need to offer you because it's available, and depending on your motivation, then it could be something that is. So until now, and I've been doing this for 20 years, I've used very successfully the vacuum erection device. It's cheap, it's available, it's safe. So my fear with the RestorX is that patients may use it when they are asleep, and that could be dangerous to the penis. And if you have to wear this at least 2 hours a day, and then you have to be naked at home, and not everybody lives by themselves. Some people live with their kids or grandkids, so it's that probably not acceptable, right? The non-conventional therapies, I don't get tired trying to warn you about these people that they want your money. So Peak Performance also offers this treatment for Peyronie's disease, not just for erectile dysfunction. And again, there is no evidence in the scientific world that proves this. It should not be offered outside a clinical trial. The same thing for platelet-rich plasma or stem cells. There is a program in Wake Forest, one of our colleagues that Josh and I know very well, Ryan Terlecki, that he was conducting a clinical trial. I don't know if he's still enrolling for these 3, but I would not do any of this outside a clinical trial. There is one? Yeah. With Nicolas Ortiz?
Not with Nico, no, with Ryan Smith.
Okay. There you go. It's closer than Wake Forest, I guess. And that's it. Thank you for staying this late. You want to do some closing remarks?
Yeah, well, just to say thank you to everyone, and also to say you've heard from a true expert. Of course, Dr. Virasoro is going to be modest, but they were really in the development of collagenase. I mean, this was a major site where that concept and treatment was developed with this guy right here. So I'm just so thankful that we had a number of experts come and that you have access to them, that they came free and gave their time to share their expertise with you. And if you have any questions about this, we'll stick around, but I do want to let everyone kind of get on with their day out there. It's a beautiful day. We are going to follow up with everyone with this content. So I saw some folks taking pictures and all that, which, you know, I do as well. Just rest assured that you'll have access to this. It was all videoed, and so we'll get that content to you, as well as information about all of our vendors and the technologies and innovations that they've shared. with us today. So thanks, everyone, and we'll be around for questions. Enjoy your day.